Okay, welcome everyone. See people coming in from the waiting room. I am Jamie Strauss-Clark, and this is the Crisis Response Improvement Strategy Committee November meeting. So appreciate all of you joining us today. Before we get started, excuse me, I'm going to do my usual overview of the technology that we use for these meetings and our requests of CRIS committee members and of members of the community who have joined us today. But before I do that, I want to mention we have two ASL interpreters with us today, Abel and Lori. They have been with us a few times. Thank you so much, Abel and Lori, for being with us today. They switch off every, I think, 15 minutes, sharing the interpreter duties. They are currently pinned to your screen. So if you do need support, ASL support today, they should be showing up on your screen. I'm just going to briefly walk through our Zoom etiquette slides. As a reminder, we have two of them, one for the CRIS committee members who are participating today and one for our community members who are observing today. So we'll start, excuse me, with our CRIS committee members. We're going to ask that everyone keep their mics on mute unless you are speaking, and that, of course, as we all know now, after 3 years of doing this, helps eliminate the background noise that might be distracting for whoever is speaking. CRIS committee members, if it is available to you, both in terms of your own personal bandwidth and your technology bandwidth, it would be great if you could keep your video camera on for the majority of the meeting. That really does help with the facilitation and engagement with one another. And the little red arrows at the bottom of the screen are showing you where those tools are. Not that you don't already know this. Can advance the arrow there, please. Great. Okay, so we do use the raise your hand function to signal when we want to offer a comment. So CRIS committee members, if you want to offer a comment or ask a question, please click on that reactions button, and then it pops up a window that if you could hit that, there you go. It shows the raise your hand button there. You can indicate that if you want to raise your hand. Advance again, please. CRIS committee members, we will be using the chat today. If you'd rather communicate a comment or a question via chat. Actually, today we're going to be having special guest facilitators. Senator Dingra and Representative Orwell are going to be facilitating the bulk of the conversation today. So during that conversation, CRIS committee members, if you have questions or thoughts to share, please send them to either Senator Dingra or Representative Orwell. And then finally, if you want to view as many CRIS committee members as possible during these conversations, please click on that speaker view button and switch to gallery, and then you'll be able to see more people. Excuse me, if you could advance the screen. Thank you. So just slightly different for our community members who have joined us today. And I want to say a warm welcome to all of you and again, express our gratitude for you taking time out of your day to be at these meetings. I'm going to ask you also to keep your microphones on mute for the meeting. And I'm going to ask community members if you could keep your video cameras off. Again, we have 37 CRIS committee members. We have 70 people participating today on this call, and it'll make it a lot easier for Senator Dingra and Representative Orwell to facilitate the conversation if they know that anyone who's on camera is a CRIS committee member. So the only exception is toward the end of the meeting when we do public comment. If you are called to make a comment, we invite you to turn your camera on at that point. Click ahead, please. And then again, speaker view, you can also put it on gallery view and see more of the CRIS committee members on your screen. I think that should do it for the preamble. The only other thing I would ask CRIS committee members, as ever, since we're not going to do the full 37-person introduction process, is when you speak today, if you wouldn't mind reminding everyone before you start speaking who you are and what organization you're representing on this CRIS committee. That'll just help our audience know who's speaking today. All right, so today's objectives. As ever, we want to understand where we've been, where we are now, and where we're going in the CRIS process. There are a few updates on state agency activities relevant to the CRIS committee that will be shared. But then, as I mentioned earlier, the bulk of today's meeting is going to be facilitated by Senator Dingra and Representative Orwell. And CRIS committee members are going to be discussing recommendations for crisis response improvement that may require a legislative fix in the 2023 session, which is coming upon us very quickly. Then we'll confirm action items and next steps. And if there's any public comment, we'll hear it then. I do want to mention currently I have no one signed up for public comment. We're gonna reserve 10 minutes at the end of the meeting. So if community members, if you would like to make a comment, please send me, Jamie Strauss Clark, a chat, and I will take as many as I can in the time allotted at the end of the meeting. So please advance the slide. Just a quick overview. So we're getting through this technology review. We're now in the welcome introductions and review the meeting agenda. We are actually not going to have a personal story today. And Bipasha will share a few words about that shortly. So we'll move right into updates after we review, after we do our welcomes and review in our meeting agenda. We'll take a break at 2 o'clock and then we'll return for the discussion that Senator Dingra and Representative Orwell will be facilitating on CRIS recommendations that require a legislative fix. We'll go into action items and next steps at 3:45 and then start our public comment period at 3:48. And so now I'd like to pause there, stop the share, please, and invite first Senator Dingra to offer some words of welcome. Senator Dingra.
Good afternoon, everyone, and thank you all for being here. I just was reflecting on where we have come since we started talking about this bill last year. And when you just think of what all we have accomplished in such a short time frame, it truly is remarkable. I know Washington is leading in this effort, but to really think about the fact that this bill did not exist last year, this time, or sorry, 2 years ago, it's still short, 2 years ago, and just the systems we have put in place, the conversations we have had, and the level of engagement we have had is truly remarkable. And I'll just share that, you know, one of the big things about this work really has been about the level of engagement we've had from such different and diverse participants. You know, this bill, when it came from the House to the Senate, in the Senate, we completely reworked what this committee looks like and what the structure of this work is. And we did that very deliberately because we wanted to make sure we were hearing all the different voices. We were hearing from people with lived experiences. We were hearing from family members. We were hearing from anyone who touches this work. And I remember a lot of conversations where people kept saying, you cannot effectively run a committee this large. You cannot have so many people at the table. Like, we don't do that. Normally you have smaller committees, you have you know, the standard people sitting around the table making decisions. And it was very important for me and for Rep. Orwell to include as many voices as we could. And so we did something creative in coming up with the steering committee, the CRIS committee, the subcommittee, because it really was an attempt to ensure that we were hearing from experts all over. And I don't mean experts in the terms of having a degree. I mean experts because they have the experience and have dealt with the work and know what the work entails. And you know, that does create issues because it is a new system. It is a new way of working. It's new to have voices around the table that traditionally have not been welcomed around the table. And so I just say thank you for your grace while we figure out how to make the system work better. But know that this is something that is very important to so many of us. And the reason why we made those changes in this bill to really have this wide coalition of people that come from different backgrounds, that are talking about different issues, have the rural and urban breakdown, have the East and the West part of Washington. We have the youth, we have LGBTQ plus individuals, we have people who come from different racial and ethnic backgrounds. It's because we really do want all your voices at the table, and just kind of understanding that this is new. This is not the way government has done work for years. It is something we've been changing in the last few years. And anytime when we try to create a new system, there are issues that have to be worked out. And I'll just say, you know, the first few meetings, the first few months of CRIS committee was really trying to make sure we all was setting the same level field, right? That we all had the same information, that we were moving forward. So I do think that a lot of the concerns we have heard from people about not feeling heard or not understanding how they're contributing to this process, just know that we're going to continue to try to refine this process, continuing to work to make sure we keep hearing from people, and that the work is going to continue to change. A lot of it was really understanding where we are and understanding what services we have and how to move forward. And so I think the work intensity is going to increase next year and the year after, when a lot of these details are worked out. I also think that a lot of the decisions that are made early on are some of our easier decisions because there's consensus around the vision. And then as the details have to be worked out, I think it can get a little bit more tricky. But I did want to, again, thank you all for continuing to engage in this work and continuing to engage in this process. And I think we all understand that the work isn't easy and the process isn't easy, but just know that everyone who's leading in this work is committed to making sure we make changes as needed. And then I, again, will go back to why all of us are here. And I think all of us are here, again, because we understand the overall vision in Washington is simply to do better. We know we have to. And frankly, I think there's a lot of consensus in how we can do better. We just have to get there. And so I am just here before our session starts to say that we're going to continue working on that journey, and we're going to continue to make the improvements we need to make sure our steering committee, CRIS committee, and the subcommittees are as inclusive, are as respectful to the expertise that all of you provide, and that we continue to move forward in a meaningful way. So thank you once again to all of you for being here and to continue your engagement.
Thank you, Senator Gingrich. And in a few moments, Megan is going to offer the land acknowledgement, but before she does, I just want to say a few words as your facilitator, and then Bipasha has a few words to share as a steering committee member. I want to acknowledge a mistake that I made in the steering committee meeting last month when we were discussing the Section 109 Tech Ops plan. Dr. Snowden, who's another non-voting member in addition to Bipasha, raised his hand to contribute. And I did ask him to share his opinion on whether or not we should proceed with a vote on the Section 109 Tech Ops plan. But in my haste to get through the agenda, I did not circle back to Bipasha, who had spoken earlier, to ask for her opinion, and I should have done that. And of course, while my intention was not to sideline Bipasha, what matters is the impact of my mistake. And it had an impact on Bipasha and potentially others with lived experience who are participating in this process, and may have contributed to a growing concern that people with lived experience are not being heard. So I want to acknowledge that to all of you. I am very sorry about the mistake. I'm going to be very mindful moving forward not to do that ever again. But most importantly, I want to acknowledge the impact and say that to all of you. And I do want to also give Bipasha a few minutes to speak, and then Megan, I'll pitch it to you for land acknowledgement. Bipasha.
Thank you, Jamie, thank you for owning your misstep. So far at almost every CRIS and steering committee meeting, we've had a person with lived experience share their story to ground us in our intention to build and expand a system that will be in service to everyone in Washington. After almost a year of this process, I decided to take a pause for today's meeting. Instead, I decided to use some of that time to share my lived experience as a member of the CRIS committee and steering committee. Through this past year, I've honestly felt overwhelmed, confused, frankly stupid many times, and even had a panic attack or two. Some of this is par for the course, as my skills are more clinical. I have minimal involvement with policy work, so the learning curve was steep, and that makes all human beings feel anxious. That's just being human. But after conversing with a few people on CRIS, I got the sense that there were enough members feeling lost, not heard, and that difficult conversations were being sacrificed for process. Members were feeling that they were being talked at rather than engaged with, and what they were saying was falling on deaf ears. This is how lived experience people often feel when interacting with systems. We talk about building a trauma-informed system, but that applies not just to people who access the system, but to all of us as human beings. How we interact with each other needs to be trauma-informed, grounded in openness, trust, honest dialogue, and a deep commitment to come together. I had to throw in that Beatles song because Rep Orwell has a presentation on 988 that's all about Beatles songs. So I really believe everyone is doing their best. I honestly do. I've looked for people to blame, but I haven't found anybody. But yet sometimes we keep passing each other like ships in the night. I am told, and I believe that many issues that have come up can be attributed to a very complex, ambitious cross-systems bill, and that's hard to implement, I have learned. But stepping away from systems for a minute at the personal level, we have here Jamie, who's bravely just owned her stuff, being open to talk to me after what happened. She's the one who named it as a microaggression. I didn't. She took full responsibility. And here she is on a public forum owning it. To me, that's what courage looks like. And I really deeply thank her for that. Part of why we do this also is because of this, the rushed nature of our meetings. And that's like a place that, you know, a lot of stuff comes up that we don't really intend to be doing at that point. So this personal journey of checking our own biases is vital to the work we're doing. And as a woman of color with privilege, I commit to doing that. And I'm inviting all of us to do the same. While it's imperative that we listen to people with lived experience, it's equally important that we can exemplify being able to have sticky, vulnerable conversations that will enable the best practices across stakeholders to surface as building blocks of a sound behavioral health crisis system. I welcome what Senator Dhingra shared. I do think that if we can modify timelines of the bill so to ease some pressure points, these are just thoughts I'm having, so that it gives us time to have meetings where we really listen and dialogue more rather than feel like we're just being presented to. And that as a steering committee, we can be clear on how feedback is being incorporated, and also letting people know why it isn't or why it is being incorporated, and reflecting on the process, giving us time to reflect on the process so we can really have a healthy behavioral health crisis response system for everyone. So thank you for listening to me. And I'm looking forward to the changes that are going to come, and exciting, better improvements and big goals to be reached next year. Thank you.
Thank you, Bipasha. So appreciated. Megan, would you like to offer the land acknowledgement today?
Thank you. Yes, I would. Let's see here. Just to follow what Jamie requested at the top of the meeting, my name is Megan Celadonia, and I work out of the governor's office, and I'm the 988 coordinator. So as a representative of the office of the governor, I would like to show respect by acknowledging the lands where our capital sits are the traditional lands of the the Ste-Ches Band of the Squaxin Island Tribe, the Nisqually Island Tribe, and all Coast Salish people who have called this land home since time immemorial. Olympia and the South Puget Sound region are covered by the Treaty of Medicine Creek, signed under duress in 1854. These lands at the southernmost point of the Salish Sea were, and still are, a place of gathering, trade, and community for many Coast Salish peoples. The Coast Salish peoples retain their stewardship of these lands and champion for environmental and social justice. Employees of the state of Washington participating today are guided by the Centennial Accord and Chapter 43.376 RCW, respecting and affirming tribal sovereignty and working with our tribal governments throughout the state and government-to-government partnership. I want to add my gratitude for the contributions of the Coast Salish peoples to Washington state and local history, culture, economy, and identity. I also want to call out the important work underway now in launching the Native and Strong Lifeline this month, and the leadership of Washington's tribes on addressing mental health crises. Thank you.
Thank you, Megan. So Brittany Elizabeth, if you could put the slides back up, I'll just walk through the decision process to remind everybody about where we're going. So I think it's, yeah, there we go. All right. So just, we do this as a practice in our meetings just to center ourselves on where we are in this process. So this year so far, we have focused on work plan and rules, centering equity in March, articulating a vision and guiding principles for CRIS in May, and then identifying crisis service gaps and goals in July. In September, I'm not sure this is quite updated here, but we did continue to examine gaps and opportunities to expand and add services to achieve the vision for Washington's crisis response system. And today, as I mentioned, we're going to focus on the legislation for 2023 and where we need some fixes. December, and I'll talk about this in just a moment, is focusing on the progress report that is due in January 2023. So if we can advance the slide, I'll just brief CRIS committee members on next steps there. So December 6th, CRIS and steering committee members, you'll be receiving the draft progress report for review. And then we're going to meet on December 13th. So we'll ask you to review it and be prepared to talk about your feedback at that December 13th meeting. There's a steering committee meeting on December 15th where they will review and approve that progress report with any comments that we've heard from the CRIS committee incorporated. And the intent is to submit it on on December 31st so that it is in the hands of the legislature by January 1, 2023. And then looking ahead, we'll be developing final recommendations to be included in the final, excuse me, I don't know why I got the tickle all of a sudden, committee recommendations report in 2024. I think that might be it for my slides here. Yes, so we, as mentioned earlier, as Bipasha shared, we are not going to be doing the personal story today, so we can advance there. I'm going to ask to stop the share now because we're going to do some updates, and I think Michelle Roberts and Carrie Waterland are going to kick it off with some updates from DOH and HCA. So why don't we start with Michelle? Michelle?
Good afternoon. Thanks, Jamie. And glad to be here with everybody. My name is Michelle Roberts. I represent the Department of Health on the CRIS committee. I serve as the Assistant Secretary for our Prevention and Community Health Division, which is where our suicide prevention work and our support for the call centers, the three 988 call centers sit. So I have a few updates on a lot of different things. So I'm going to cover where we're at with the implementation of the 988 three-digit dialing code. Some exciting news that's already been mentioned about native and strong lifelines. Some more, a little bit on rulemaking listening sessions that we've had that several of people have participated in. And a little bit of news about our SAMHSA funding. Okay, so I'm going to jump right in. So really excited around 988 implementation. Things continue to move forward really successfully, and that credit goes to our three call centers and the incredible work they've done to be ready for the go live date. Our state's answer rate for August 2020 was 90% for 988 calls. That's incredible. I think we have shared before, that's pre-implementation. We were averaging between 55 to 65%. So definitely shows what some coordinated effort and additional funding for staff and training and support can get us. So that's really, I'm just so proud of that work and everybody who's helped support it. Our text and chat answer rates were both 100% in August. Our state has seen a steady increase. So in text and chats, and so that's 58 text and chats interactions were per day in August. And that was up to 73 interactions in September and more than 100 in October. So really growing capacity and awareness that that's another way that you can reach 988. So one thing about this to know is that an average call takes about 10 minutes from start to finish, and an average text interaction from the first text to the last takes about 23 minutes for text. And then for chat interaction takes about 45 minutes. So this is a longer interaction time with people who are seeking services, and that impacts funding and staffing and a lot of different pieces on the back end. I want to share also that we've not received our September 2022 state metrics yet for where we're at with some of our call rates in state call rate answers. So Vibrant at the national level did a network-wide upgrade to the voice platform and telephone platform, which caused impacts to ring times for inbound calls. So that was something happening at the national level. So this reduced ring time by about half and impacted the in-state answer volume. So that's happening nationwide. So Vibrant's working on a solution for this, but no ETA on when the states will receive our September metrics. And just last thing about the call centers and implementation, they continue to hire our 3 call centers as needed. And right now all feeling like they've got adequate staffing levels to answer 988 calls. Okay, I'm going to transition to the Native and Strong Lifeline. So really excited to share the incredible news that the Native and Strong Lifeline launched on November 10th, so last week. That's operated by the call center of Volunteers of America. So what this means is people who call 988 from a Washington state area code now have the option to choose a dial pad option when you answer, which is option 4, to be connected to the Native and Strong Lifeline. The Native and Strong Lifeline is the first program of its kind specifically for American Indian and Alaska Native communities. And when we say first of its kind, first of the kind in the entire nation. The line is answered by Native counselors who are tribal members and descendants with close ties to their communities. This has been incredible work of a deep partnership between many, many different partners, really being led by our tribal communities, and work around a behavioral health hub in the state that has led to this identifying this need, trusted relationships, and working together to implement the solution. We are holding a media event at VOA on this Thursday, November 17th, to celebrate the launch of the line and the partnerships with our tribal communities and others to make the line possible. So we will share a media advisory and a press release on that day. And Vibrant is also going to highlight this work nationally with a press release on Friday, then November 18th. So incredible work that we should all just be honored and very proud of to have happening in our state. Okay, I'm going to move into some of the rulemaking work we're doing. So I think I've shared before that 1477 legislation asked the department to set up rules around standards for crisis call center hubs. So that rulemaking process is underway. DOH has hosted 2 listening sessions so far on November 3rd and November 10th. We have a 3rd listening session tomorrow on the 16th. The first session was for people who've called a crisis line themselves. The second listening session was for people who've called a crisis line for someone else. And the 3rd session is for crisis call center staff, responders, and behavioral health care providers. So feedback and information learned in the listening sessions will be used to draft the standards for crisis call center hubs. Again, these are listening sessions. They're not problem-solving sessions, they're listening so we can think about how we can use these feedback and lessons learned for our future work. The next step is that the department will draft rule language, and then we'll have 2 workshops that are open to the public to look at that draft rule language. And those sessions are on December 13th and December 15th. Okay, last piece I want to share is around some SAMHSA funding that the department has received. I've shared before that received a one-time SAMHSA grant in April 2020 to help build 988 capacity. And that's federal funding to help us with the implementation of 988. This is one-time funding. Earlier this month, some good news is SAMHSA offered us some supplemental funding to expand and enhance 988 activities. It was a very quick turnaround, only a week from the federal government. So that was a little frustrating, but we did apply for those supplemental funds. And they are really focused on, and this we're focusing this funding on enhancing of the whole system, and it's including ongoing work with Healthcare Authority to develop a best practices guide for mobile crisis response. And that guide will support standardization in mobile crisis practices statewide and will be used to train mobile crisis teams as well as caregivers and specialized systems for care for aging populations. So again, that's work we're doing with Healthcare Authority, and we'll keep everybody really informed of that because I'm sure there'll be opportunities to give us some input along the way. The other area we're going to use this new funding to advance activities outlined in Washington's technical and operational plan for 988, which is what was approved at the last steering committee. So technical expertise will be used to develop a variety of process maps, identify data and metric requirements for the Common Call Center platform, identify privacy and security requirements for the Common Call Center platform, and identify technical design requirements for the interface needed to coordinate between the crisis call centers and crisis response services as we look at the whole technical platform going forward. So those are my updates, Jamie. And I don't know if we want to take questions or we're going over to Carrie next.
Yeah, why don't we pause there and see if there's any questions. I do see one in the chat, which is if people in this meeting have rulemaking input for your team, Michelle, where should they send it?
Absolutely. Let me get back to you. Well, you can always send it to me. So we'll make sure you have it. But I do think we have an email address. So let me, one of my staff here could message me to make sure who are listening to make sure I have that address.
Michelle, if you send that to me, I'll make sure it gets out on the chat to everyone. Claudia, you have a question.
Yeah, Michelle, last meeting I asked about if it was possible to receive in the update the number of interpreter services that we use of different languages of people calling the call centers. I'm not sure if that information is available at this time.
Claudia, thank you so much. I had completely forgotten about that. So that's mine to own. I'm not sure if my staff did, but I was out with a family emergency much of this last month. So let me check into this to make sure. And I'm going to make a note of that so we do not forget for the next meeting. But let's see what we can pull together and share with you ahead of time and make sure we share with CRIS at the next meeting.
Okay, so maybe we can add that to our action items.
Thank you.
That I'll summarize.
It will help us track it.
Excuse me. Any other questions from CRIS committee members before we move on? Okay, and I promise folks, this is, as we said at the beginning, this is the presenting to you piece, but then we'll get to the dialogue piece very shortly. Carrie Waterland, I know you are in transit here. Do you have any updates you want to share?
Maybe I am checking in to see if you can hear me at all. Can you hear me?
It's a little muffled, but let's give it a try and see.
Yeah, we may have some issue. Sorry, all. I am in New Orleans, and I will try to speak loudly so that we can get our interpreters. Okay. I will not cover, I think, many of the things that Michelle covered for us. The technical and operations plan has been approved by the steering committee. It is also accepted by the OCIO, so we are moving forward on that. I do want to let folks know that in addition to what Michelle shared, we do have a request for information proposal process that is beginning. That RFI will be circulated for review and refinement soon. We will be working with the unified NSPO group that represents all three to review that RFI. So wanting to let folks know that. Also, in addition to what Michelle said, just some time frames. The mobile crisis response manual and program guides have already been completed, and those are currently with the BHASOs and behavioral health providers for review. The work groups will be being formed and beginning to develop the crisis best practice toolkit, which is what Michelle was talking about. That's that joint effort with us, which will include dispatch protocols and high-risk guidelines or guidelines for dealing with extra crisis situations to make sure that there are protocols and things for that. Wanting to let folks know also that the next day work group has come to a consensus regarding the coordination with commercial partners and implementation is expected to hopefully land within the time frame of the bill and how that's recognized. And then just a few more updates for people. One, wanted to let people know, in keeping with the theme of really needing to ensure that we have lived expertise and experience on this committee, I will say here is something that we will own. A recommendation regarding a vacant spot. We have a vacant spot team for lived experience members that is right now making its way through the lived experience CRIS committee to make sure that they are making a recommendation, folks from that committee, who then will give that recommendation over to me. So we'll make sure that that gets filled as soon as possible. And then the last thing that I wanted to share is another piggyback off of what Michelle shared, which is that healthcare authorities, in partnership with our Office of Tribal Affairs and the Office of Tribal Affairs in partnership with the tribes, has submitted agency request legislation from healthcare authorities that seeks to modernize the Involuntary Treatment Act. And it really seeks to recognize the role of tribes and our tribal partners in the Involuntary Treatment Act. Some of these things are ensuring that tribes really do have a right that is clear to intervene in Involuntary Treatment Act proceedings, ensuring that there's access to culturally appropriate and culturally relevant healers, ensuring that designated crisis responders are there to collaborate with tribal law enforcement. And it also adds that HCA, Healthcare Authority, is required to consult with tribal governments around the designated crisis responder protocols that we have in place. Wanted to let folks know that that bill is working its way through the governor's office. We know that there will be potentially some proposals that will change the way that that bill looks right now during the legislative session. But we will notify anybody of any potential policy changes, in particular to that agency request legislation, as soon as we know those. And with that, I will take any questions. And I apologize for the sound.
Carrie, thanks so much. I know you're at a busy conference, so thanks so much for taking time out to share those updates. Any questions for Carrie? Okay, I'm going to circle over to Megan. Megan, I had heard you would just share an update on the steering committee discussion last week on section 109 tech ops. I know Carrie just mentioned that it passed, but is there anything you want to add to that?
Well, let's see. So I was on, Jamie, to talk about outcomes and measures update as well. Did you want me to start with that? And then
oh, sure. Yes, of course. Absolutely.
Okay. So just a couple updates today. So what I was going to talk about is the expectations of 1477 related to outcomes and measures, what we're doing from a cross-agency perspective, and just next steps. And so just a couple of key talking points, couple of, well, I have slides on my screen, but we don't have to show them to the group right now. I can just speak from them. So in terms of 1477, we know that there's a comprehensive assessment that's required by the steering committee. And that's outlined in section 103, section 5, and it requires the development, among many other things, of a process for establishing measures, benchmarks, and improvement targets. And what we've been doing in terms of trying to at least begin to chip away on that is we are working cross-agency between Healthcare Authority and DOH. We have a project management structure in place to support all of the work that's shared across that bill. And part of thinking about this project and setting our path forward was really thinking about, if we do this work right, what will it look like? What should we see happen? So if we think about the call, respond, go categories, what do we think it'll look like if we do it right? So this is just kind of brainstorming, right? Things that we think would happen if it goes well. And then based on that brainstorming, just developing, and this is what we've done so far, a list of already established measures and targets that we currently collect, and trying to indicate if a best practice exists around that, and if so, who owns that best practice. And so we've done that as well. And so we're trying to work to refine that list and take it from there. so to speak. And so in terms of what we're doing moving forward is finalizing that list and then thinking with the wider perspective on what type of resources may be needed to be assigned to take this to a statewide level. So if we have an understanding from the agency project on what looks like good work, how do we really take it to the statewide level, which is what the bill requires. And so, that's my update right now on the work that we're doing around setting measures and targets to support the information that's needed in the comprehensive assessment. And then moving on to tech and ops, I think several of the things that I was going to update on have already been mentioned, which is great. We know that the steering committee approved this plan back in October, the 25th to be exact. We also know that we have conditional approval on that plan from the Office of the Chief, so the OCIO, Office of the Chief Information, or I always mess up this acronym, the Chief Information Office. We have conditional approval from them. And so what we're working on now across agency is really an RFI process, a request for information process, which was part of the plan that Carrie already mentioned. And this is really an information gathering step. So if we look across the landscape of potential vendors, who's out there and who might be interested in the work. And that's all I have today, Jamie.
Okay, thank you, Megan. And Carrie, can I just turn it back to you? We did get a question from a CRIS committee member asking, when will the decision be made on who will fill the vacant role on the lived experience subcommittee? So Carrie, if you don't mind just jumping in there.
Yeah, thank you so much, Jamie. I will tell you that I have soon on my touch point. We hope to have that name by the end of the month, but I do know that the team is taking, I think, a handful of names to the lived experience subcommittee to walk through those names with everybody on the lived experience subcommittee to then give a formal recommendation. So we're shooting for the end of the month. And I am looking for any friendly faces that may be able to tell me when that next lived experience subcommittee might be. That might help me a little bit. Or we might be doing it out of cycle. So again, I've got soon and hopefully by the end of the month. So I look forward to hoping to give you an update at our next month's meeting, if not earlier.
I think that we're not, hi, this is Puck, I'm a lived experience person. We're not planning on going to the whole lived experience meeting with the applications just for privacy / personal information reasons. As much as that's masked, it's still a lot to take through the whole committee. So Bapasha and hopefully our other member Michael and I are going to look through. I've committed to getting that back by the end of the week, so hopefully we can get that together.
Thank you so much, Puck. I will then commit to making that time frame so that I know that there is a small and mighty team helping. And Puck, thank you, by the way, for bringing up and raising up the confidentiality concerns. I really want to encourage everyone to know that we are respecting, for those of you that applied for this open seat, we're respecting confidentiality, taking away as many pieces of information as possible that folks may not want as you're reviewing. So thank you, Pucko, for reminding me that this is a smaller group and for giving me that time frame of when you believe that you'll have your review and recommendations over. So I appreciate that.
Thank you, Carrie. Thank you, Puck. I see another question here from a CRIS committee member. How can we see the final version of the 2022 comprehensive assessment? So Betsy or Nicola, is that something you can answer?
Hi, Jamie. The 2022 version of the comprehensive assessment, I can provide a link in the chat. It's called the initial assessment, but the report submitted last January is on the CRIS webpage, and I'll insert a link into the chat so that it's
okay. And Ron, please let me know if you meant something different there, and we'll. Okay, great. Any other questions? Jen Stuber. Oh, Jen, you're on mute.
I just wanted to raise my voice around some procedural things. So the technology report, like how that was handled, I think was a little hard from the standpoint of at least me as a CRIS member. I never really felt like there was a great opportunity to really discuss that report at any level in this body. And the timeline was extremely fast to provide review of a very complex report. And I worry that ultimately we don't really have good feedback and we don't have really good perspective from some of the most important people who need to be consulted around that decision making, including our call centers. I'm aware of the fact that their input was provided on a number of different occasions, and I don't think they ever had their perspective really incorporated or responded to. So, coming to the report that's due in December, that concerns me as well. When I saw the slide you all put up about us basically having a week to review, and then you guys are basically having 2 days to integrate our comments before you vote on it as a steering committee. I mean, I just don't think that's really a process that can really be successful in terms of our ability to provide meaningful input. Thanks.
Thank you, Jen. I want to pause there and see if any steering committee members want to add to or respond to that, or if that's something that you want to noodle on and come back.
Well, I do just want to speak up to the call center input, and we have reached out to the call centers and we have regular meetings with the call centers, and we want to keep our commitment is to that space, to making sure we're driving the work in a direction that is going to work for the 3 call centers as the entry point for all the other pieces of the system we're building together. So you have that commitment from DOH. We are responsible for that beginning piece of the work and the next steps. I also just want to share and I think this got lost, and it was a quick meeting for the steering committee, even though there'd been a lot of discussion in other places, but the technology report is a starting place for us. It's not a final plan. It's kind of a draft of steps. We're still in information gathering phases. That is the next step. That's what an RFI process is. We're watching very closely what's happening at the Vibrant level with their platform and continuing to learn and understand that. So I guess I'm sharing that to say, we appreciate the feedback, and there's going to be a lot of other opportunities to continue since we are still in an information gathering phase of our work. We're pretty far from any final decisions on that work. So we will keep making sure there is time and space.
Thanks, Michelle. I did get a comment in the chat here from a CRIS committee member echoing Jen Stuber's comments. And I see Ron Harding's hand up. Ron?
I guess I would just want to echo Dr. Stuber's point as well, and kind of ask that question with, how do you process input in that short amount of time in 2 days? How does the steering committee do that?
I take that as both a question and a comment. So I'm going to pause and see if any steering committee members want to, or if any steering committee members want to respond to that.
I can jump in and just say, as a steering committee member, there's stuff that goes in the report, but the feedback and the comments that are sent is also information that we read. I think one of the challenging things about this process, and I'm hearing from all of you, is something that Bipasha mentioned, was the timeframes and the timelines that are put in that are creating this rush to get this done before the legislative session. So I agree, we have to have a different process. But the timelines, unfortunately, are driven with just the ability to get the reports done and the legislative session starting, and the reports that are mandated to the legislature. So I think this is where, when we are going to talk about legislative changes that we need after our break, I think it's a good time to also talk about, do we make some changes to when things are due and when they're due to provide more time for providing this feedback. But I think if anyone has other suggestions on how we can accomplish getting more feedback or incorporating that, unfortunately, within the timeline set for this year, I know I'm definitely open to hearing that. But we have this legislative session starting that we have to make sure we're prepared for. That's driving a lot of this. But I agree, we have to figure out how to do a better job of incorporating feedback in a more meaningful way.
Thank you, Senator Dingra. I see Representative Orwell's hand. Representative Orwell?
No, thank you. I appreciate the comments that have been made, and I was going to say this later, but I think I'll share it now. The legislature, we pass a lot of bills and they get handed to our state agencies to implement. And we talk all the time about 1477, but this isn't about a bill. It's about building a new system. And for us to be really creating it, it has to be in partnership with the community, and we have to elevate the voices of people with lived experience. And so I'd like to see everything slowed down. I'd like the process. And I think, and I was the one that opposed the IT plan because I'm very conscious. I want us to lead in a way that's more clinical and healing, and that's kind of our first step towards our system. And I worry about the IT wagging the dog, right? This is so much more than an IT question. And so again, I appreciate the comments about taking our time. I think part of our legislation has to be to change some of these timelines so we feel like we can go more in depth. And so again, I appreciate everybody here today and in us continuing that dialogue.
Thank you, Representative Orwell. Dr. Snowden.
As a member of the steering committee, I'd like to say that I would respectfully disagree. I think in my experience of that meeting, it was probably one of the most frank and difficult discussions we've had. And what that said to me is that I think people did know what the issues were. The fact that we weren't in all agreement, I don't think meant that we needed to slow or stop the process. But to me, the fact that we were able to have frank discussion about the concerns and areas where we differed gave me faith that the process was working.
Thank you, Dr. Snowden. Are there any other comments on this particular topic? Senator Dingra.
I'll just add that I think there is the reality that there is urgency to this work as well. And trying to balance the two is important. I mean, one of the main reasons why there hasn't been really extensive outreach or advertising of 988 is because we really don't want people to call that number and have these expectations on what that means and not be able to deliver. And I'll tell you, I'm the one who really pushed for fast deadlines because I wanted this process 10 years ago. And so, how do we make sure we keep the momentum going and develop that work while trying to have an inclusive process? And I think it is very challenging to make those balances. I also think this is work where a lot of people know what the best practices are and what we should be doing. I do think that there's consensus around there. So I will tell you, especially to Dr. Snowden's point, that it is this balancing on where we are making, in my mind, thoughtful decision, having heard from people. I understand there's some people who feel like they've not been heard, but that urgency of saying the system is literally changing lives. And do we want to wait for 5 years to do this? Or do we want to do it in 3 years? Or do we want to do it in a few years? So I think that balancing is hard. And I think it's always challenging to get to the right balance. So I do have some urgency where I do want the system up and running. And so we had also made concessions to this bill and had moved timeframes. I think the original version was a lot quicker than what we currently have. So, so I'll just say that I think it's something we'll just continue to work on to see how we can strike that balance. But I do want to make sure we do not get rid of the good for the perfect, right? We still need to continue to move forward and continue to do this work with that sense of urgency, because I do think that people get distracted by shiny new toys. And the momentum that we have in the legislature around this work is actually critical in making sure these bills continue to pass.
I just want to reflect on what we've heard in this conversation and appreciate Jen Stuber kicking it off and the dialogue that we've had. Circling back to what Senator Dingra said in her welcome remarks, clearly we need to continue having these dialogues about how to improve our process so we can achieve that balance, like Senator Dingra said, between meeting the urgency of the moment and having an inclusive process where we are listening to each other and incorporating that feedback. So I think this is a conversation we need to continue, and as we're planning upcoming meetings, we'll make note of that. I want to just check in. Any other thoughts or feedback before we move on here? Megan, you just came off mute. Are you looking to add something?
Well, I just wanted to reiterate, I think, a little bit with what Michelle said, is that RFI or the Tech and Ops plan is really a process document of how do we move from here to the future. And so we have so much planning to do and so much time to do more engagement and understand priorities. So I just wanted to reiterate that because we have a lot of work ahead, and I don't think we missed, if people are worried they missed the boat, I think we have a big boat ahead of us with lots of engagement and discussion.
One thing I might add there is I think it might help to bring back to this committee what you, the steering committee, have heard and how that might be incorporated into future decision making on Section 109 Tech Ops. So that's just food for thought. Puck.
Side chat that I've been having with Manka is one thing that Bipasha and I have done to go through some of the documents and text has been to get together to go through it and figure out our concerns and ask each other questions. And so I'm willing to invite other people to that process, and maybe we can have someone there who knows things about it. So I'm going to be emailing you probably, Jamie, and other people. And then once we have more of a timeline, we can set a time and hopefully invite other people for whom their brains process information that way to go through that document.
That is a lovely offer, Puck. Thank you so much for that. So I'm hearing opportunity to use each other as a sounding board and discuss what you're reading. So thank you for that. And I'll look out for your email and make sure everybody gets access to that. Senator Dingra.
I was just going to add, you know, if you want to talk about like the policy component of it, since we are looking at drafting legislation for next session, I think since Rep. Orwell and I speak for each other all the time, I think we can maybe ask some of our policy staff or caucus staff to attend, and that way they can kind of provide either expertise on the policy or background on why something is there, or just provide more context. So, you know, I'm happy to have my LA or my office help coordinate that, but we can definitely ask our caucus policy staff if it's specifically related to legislation for next session.
That's great. So we have two resources offered here, CRIS committee members supporting each other in being sounding boards, and potentially legislative staff supporting that process. Representative Orwell.
Yeah, no, I think that's a great idea. And also I will just also point out that Zoom is very hard these last 2 years versus not being in person. The other thing I'll just say is, you know, when I say slow down the timelines, I'm talking about IT. I think the one thing we cannot slow down is the clinical services, right? The rapid response teams and really responding to the call. So I just want to kind of clarify that I'm not looking to slow down everything, but I just don't want the IT driving the clinical. Thanks.
All right. Well, I'm glad we had as much time as we did for the updates because that was a good dialogue. It is just coming on 2 o'clock. Let's take a 5-minute break. And then when we come back, we're going to turn it over to our guest facilitators, Senator Dingra and Representative Orwell, to facilitate the discussion about legislative fixes. So please be back on at 2:05 with your cameras on, CRIS committee members. Thank you. Okay, it looks like we need another few seconds to let folks come back on and turn their cameras. So we'll give it another sec here. Okay. All right, I see folks coming back on. Welcome back. So as mentioned earlier, Senator Dingra and Representative Orwell are going to facilitate this conversation. And I believe as a group, we're not going to do breakouts today. So as ever, this conversation is specifically for CRIS committee members. So members of the community who are here today, we're going to ask again that you keep your video cameras off and reserve the chat only for CRIS committee members to communicate with Representative Orwell and Senator Dingra. CRIS committee members, please use raise your hand function to engage in the conversation, or if you would prefer to communicate by chat, please send that chat to, we'll make sure, actually Brittany, I think we probably need to make Representative Orwell and Senator Dingra co-hosts so that they can proceed. Okay, wonderful. You're way ahead of me. Fabulous. So please send your chat either to Representative Orwell or Senator Dingra. And I will track time and just give you, so you don't have to worry about that. I'll give you some time cues so that you know when you need to start wrapping up the discussion. All right, everybody, I'm going to turn it over to our facilitators.
Thank you. I'll just start us off, and I'll just say it's I actually love talking about policy, so I'm very excited to have this conversation about legislative bills and changes that we need for next session. So I'll just say we sent out, I think, a list of a few things that are on the agenda. And I'll just say the way that Rep. Orwell and I came up with that list was basically everything that we've been hearing from people over the last year and a half. And so there's an attempt for us to capture only those issues that need legislative fixes. So we're not talking about things that are done through rulemaking or other policy staff. This is very specifically about changes that we have heard people say are needed. And so we did divide it up between a few. And so before we go through that list, I'm sure Rep. Orwell will start us off by saying something, but I just want to say that this is a time when bills are being developed and feedback is getting incorporated. And so this is the right time for us to really be thinking about what do we need changes, what specifically are the issues. So the things that we're going to run through in detail and then open up for a much broader conversation about any other ideas or issues people have. First, we're going to start off with the 23-hour crisis facilities, what that facility looks like, what the details are around that. We're going to talk about workforce development. So any and all ideas and suggestions people have. We're going to talk about liability issues and for the work that we're doing here. Training, resources for crisis responders. This is cross-training between 911, 988, rapid response team. Other items that are related to 988 that everyone would like to bring up. But I want to start off by saying that one of the changes that is definitely going to happen is ensuring that the person with lived experience member will be a voting member on steering committee. So that is, I just want to state that that's going, and that was an oversight. I assumed that was in the bill and turned out it wasn't, because I really, again, trying to build a system that is inclusive and creating committees that look differently than they normally have in the space was important. So that's already on there. And then we'll turn it over to Rep. Orwell, and then I'll take it back to have the discussion about the 23-hour facilities.
Thank you, Senator Dingra. And I'm excited about this conversation too. This is our time to kind of dig a little deeper in the policy and really hear from all of you. And I do think we are building a new system. And so some of the components we are talking about today don't exist on a large scale. So I'm really excited about that. I also want to recognize that our crisis system has caused a lot of trauma. And we're trying so hard to create one that is more healing, more trauma informed, but this discussion may be difficult and it may be triggering for some people who have had bad experiences. So I just think if we can all be sensitive about our language and just really find a safe place where we can have this dialogue. So again, thank you.
Thank you. And I'll just say, please feel free to speak up. This is not meant to be a presentation. It's meant to be more of a discussion and talking about ideas. So we're going to go ahead with the raise hand feature. That way, if you have a question, comment, or what about this, just go ahead and raise your hand, and Rep. Orwell and I will just take turns calling on people. So I wanted to start off with the 23-hour facility bill. This is something, we saw in Arizona, and I think it is just so critical for this work. We have, oh, great. I'm glad Rep. Davis is here because she's here for the workforce discussion. We are running about 5 minutes later, Rep. Davis. So if you have other work, you can do that. So it was really important that when people are in crisis, there's a place that they can go to that is not the jail, that is not an emergency room, if that is not what is needed. And so one of the issues we've seen in Washington specifically is that there are a lot of barriers, frankly, to the crisis stabilization centers that we have. We have 2 facilities that do this work. It's called the triage centers and the crisis stabilization center. So we finally first said, what's the difference between the 2? Do we need to, or how are we going to do it? So this is a new facility type that we are suggesting. And it is one that's going to be, it's a 23-hour crisis service. So it's not meant for long-term boarding. It's not meant for long-term stay. It really is where you go in, you're able to assess the situation, you provide short-term care. We really want peers to be involved in here. We really want to make sure that they can take walk-ins, ambulance, fire, police drop-off. Anyone can go and access this facility. We also want to make sure that this is not a facility that is going to require medical clearance. This is something which is a very Washington concept, where a lot of our facilities require you to be medically cleared through an emergency room. And, we saw this work in Arizona, where that facility has someone who can do like a quick medical checkup. And so the vast majority of people actually don't need to go to an emergency room to get that. They're able to do that at the facility. And I'm sure Rep. Davis can chime in on that as well. And we do want to create some flexibility that in case someone is waiting to be transitioned to another care facility or to an outpatient program, that if they need a few hours beyond the 23 hours, that flexibility is there for a certain, short amount of time to help with that transition into another service. And so, but we definitely don't intend for the 23-hour to be continuously used. Like, you can't just continue to extend that. So one of the suggestions around this was ensuring that these facilities, which the plan is that these are state-sponsored facilities, which means that the state pays for them. So this is not a facility where people will be like, oh, what kind of insurance do you have? Are you able to pay out of pocket? None of that. You show up, people welcome you in, and the state picks up the tab for them. And because of that, we can then mandate again that there's no medical clearance required. We also want to make sure that they don't have criteria for not accepting anyone. It really is meant to be like a no wrong door concept where everyone is welcome. Let's see, what else does this have? I'm taking a quick look at this on here. And so I'm happy to open it up for more discussion. We are going to require that this facility have some kind of understanding or relationship with an organization or a place that can provide some kind of supportive housing or transitional housing that is more than 23 hours, because these facilities only work if you can transition people out of there to the next level of care that they need. So that is going to go into the bill, is really making sure that that connection is there. I've been very excited that a lot of our hospitals have been really interested in this facility and seeing how they can be a part of helping out with having them. And so I think there will be a lot more on that. And Rep. Davis, Rep. Orwell, feel free to jump in if there's anything else on the bill that I may have missed.
Well, Senator Dinkra, we went around the state to do a lot of different locations, and there is interest all over the state on these 23-hour centers, but we're also hearing some need for clarity on the licensure. There's been historically the use of residential treatment facility WACs, which are very difficult. And so I think part of this discussion is really understanding how this facility is licensed.
Yeah, and I think we really want to make sure this is not a residential facility. It really is meant to be something that's 23 hours. And so we're really hopeful that the permitting and the licensing will be easier than the past. So would love to open this up to share your thoughts on providing these facilities. I would love to have them all over the state, especially while taking a look at our rural partners and ensuring that when we look at the state, we are able to geographically place them all around. Kashi.
Thank you. My first question is not going to be shocking. It's about if kids go to those facilities or if there's kid-specific facilities. And then I have a couple of comments, but wanted to ask that question first.
The minute your hand went up, I'm like, oh, I should have added that. So right now, what we're looking for, what we're saying is, this is called the living room model, and these are for adults. We've been talking about the Starbucks model, and I think that's what we're talking about with the teens. It's not clear that the teens need 23 hours. They may need something slightly different. And so there's a lot of interest in seeing if we can do capital dollars made available for youth. But we're very interested in seeing that. I do think it needs to be, the model needs to be slightly different. I haven't heard anyone say that this is the model we want for our youth. So anyone else who works with youth, I'd love to hear that. I do think they need something slightly different, and we're very happy to see what we can make available. We don't have a bill draft on it, but we are looking at making capital dollars available for people to do this work. Rep. Orwell?
Yeah, thank you, Senator Dinkra, and I appreciate that question. You know, we do have a youth planning group in South King County, really looking at what would a youth facility look like. And I see Claudia's here, and I don't know if you want to weigh in at all, but it does seem, especially when you're looking, you know, I know that the children's and youth teams like to do a lot of the services in home, but it does feel like there's a need for, I don't know, 12 to 17 or some age group to potentially have a place to go in crisis. So Claudia, I don't know if you want to weigh in on that.
Claudia, I can't
Sorry,
hear you.
I think, sorry, I was muted. Just want to add, there has been a lot of input from the community where they want something different. Families want to get involved. We got some meetings with youth, with the youth were saying we really want a place who's just totally out of the box, nothing that looks like a place that exists right now, a place where they feel welcome, where it's run by youth, where it's peer supported, where you have people who have living experience that can support them. So it's been a lot of input, but definitely the input is something different that we don't have right now.
Yeah, we've done about 5 focus groups with youth. And again, I think we have to really hear, you know, does it have an art studio or music, or like, how does it look that it would be welcoming for youth?
Thank you. Can I just make 2 quick points? I think they're still relevant for adults as well. I do think kids really need a place to go, and I'm really excited to hear about the focus groups that take in feedback from youth. I would just mention the critical importance of case management or care coordination. People will have a hard time getting out of 23-hour facilities if they don't have a good plan lined up for that. And so I'm probably preaching to the choir, but peers can play such a valuable role there, and that makes a huge difference in trying to discharge from a facility. So I will at least reiterate what is probably obvious. And then I think one of the things we've been struggling with in the hospital setting, and this, I'm just acutely aware of this right now, is good training for staff in different levels of abilities, right? Developmental disabilities and autism spectrum. And there are adults with developmental disabilities and on the autism spectrum and intellectual disabilities who will go to these centers. And we don't do a good job of training providers in how to work with folks with ASD and IDD. And where I think the system is really struggling to meet the needs of that population with co-occurring intellectual developmental disability and behavioral health challenges. And so as we think about the no wrong door, you know, I would really, with an equity lens, take, you know, an approach of making sure our staff can really work with everybody who does walk through that door.
Thank you for that, Kashi. And, you know, part of saying that this is going to be paid for by the state, we can kind of talk about what those teams look like. So we do want to be thoughtful on what is the staffing level at this facility. And we've talked about the need for having a RN who can kind of help with the medical clearance, having someone who can do substance use disorder assessment, having the mental health professional, absolutely having a peer. They're critical to that. And next up is Rep Davis talking about her peer bill. So more on that. And then Rep Orwell will be talking about the training and the credentialing issues. So this is the right time for all of you to be thinking about what does that team at this facility look like? The last time when just as legislators had met, that's when Rep Davis had said, we need to mandate that they have that connection with another agency or organization that's going to do the transition planning. To what you had said, Kashi, is really making sure that that is that setup so people then aren't stuck in this facility, that there is really a warm handoff to the next level of care that's needed. So those are the kinds of ideas we're looking for. If anyone has any suggestions, and it doesn't have to be right now, you can even ponder it and think about it. Even once the bill is dropped in session, that's again where we have to continue thinking about really, if you imagine yourself showing up, how do you want to be treated? Who do you want to make sure is there? And what would aftercare look like for you? So are there any other comments, questions about the 23-hour facility concept that we're thinking about? And I'll just say there was a question about citing and local credentialing and all of that. And we are working with some of our cities on that. And I think this is where the liability discussion that we have coming on will happen for the cities to do this work. Surprisingly, well, we'll see what happens with the 23-hour facilities, but I know that, Kirkland and some of these East Side cities are actually working together on creating one of these facilities, because King County came up with the 5 facilities they're talking about. And not to jinx it, hopefully we should know in a week, if not sooner, about the space they're getting. And Kashi, to your point, there's actually space. And I literally just pitched them that, hey, 1 floor, maybe you can convert that into a fun youth facility. So more on that. But I think we'll continue to work at citing issues and what's going to happen around that.
Senator, it's Jan Tokumoto. I was wondering if in this bill there would be some consideration given to
Jen?
Sorry, can you hear me?
I can hear you now, but I just heard there'll be some consideration given to, and I don't know what that
given to having funding so that that's built into this, because having run a 2359 before, I know that discharge planning has to start at the time of admission because you have such a short length of stay. And so in other projects that Frontier has taken on, we've built in resources so that we were guaranteed there was a housing resource or a resource with a substance use provider that we could immediately access, because we knew that there were some resources that were really at the top of the list of what these individuals would need for that transition back into the community. So I was wondering if there could be any consideration given to that.
And we can talk more about that. I think for this bill, the state was going to pick up the cost for this facility. And so the facility, running the facility, and then just require that facility have those relationships with organizations that can provide the aftercare. I think funding for all of that, there's lots of other bills around that, but for this bill, it was more about the requirements around this facility type. But send me some more specific thoughts that you have around there. But eligibility, benefits, all of that starts playing into it. For when you transition them out of the 23-hour facility, is what kind of insurance they have, what would they be eligible for, what they won't be eligible for, that kind of stuff. But I think if there are any ideas around that need legislative fixes, that's definitely the time to do that.
Okay, thank you.
And then Justin?
Yes, thank you. Senator Dingra and Representative Orwell. The ASOs are going to be providing, again, feedback. Thank you for putting out the information, be able to share a little bit from our perspective, but just wanted to just highlight those key areas. I think some of them we've already covered. Again, the licensing requirements around what is expected, especially with providers when there's a lot of ownership on them, on the expectations they have to fulfill, puts a lot of concern, I think, on the longevity or sustainability for them to take on a project. And that is always challenging, is if we put all the expectation on them, including that there is no wrong door, so they take everyone, that also means if we don't have a complete or continuum of care that allows for those individuals to then receive those services, especially housing, then we end up just creating another choke point for a lot of individuals in terms of what is the best care, and that's inadequate, even if it's the only one available. And then we lose those providers that would provide the service. One of the key points I keep going back to is respite and sobering services, which used to be ubiquitous in our region, but because of the overwhelming and complex nature of most of those individuals, we've seen most providers step back, and those are desperately needed to really carve out individuals who don't need a higher level of acuity. But what we found is because those providers aren't there, because of the challenges associated with the facilities, we've seen those individuals gain in acuity and go to a higher level, which again is not what we want. It's counterintuitive to the recovery-based service that we really want to provide to individuals. And I think the second aspect is the challenge again with funding. I know you speak to that the state really wants to fund that. We also know there's partnerships not only with commercial and Medicaid to really have set agreements that pay for the necessary services that are being provided. And also, if and when those services require higher acuity, ensuring that those individuals, those providers are made whole to the sustainable model, not only in with the challenges they'll be facing, but also with the very complex comorbidities we're seeing across many of the members that are seeking those services. It's not as simple as saying they have some mental health or substance use. No, they have very complex and integrated medical components that are often overlooked, and this facility may not be designed best to suit that. And the third component I would throw out there too, again, is it must be done in conjunction with the existing resources that are being pushed out by Department of Commerce. Speaking on behalf of our frontier rural regions, we would love more resources. But when these facilities have come open, we're losing providers, and that has constantly put us in a vacancy. So strategically implementing these resources along other ones is key to ensuring that our providers who are doing outpatient services don't lose individuals with, again, if you don't have a good outpatient provider, acuity goes up as individuals begin experiencing stumbling in their recovery journey because they don't have that constant support. And that's not what we want. And then secondarily too, we see a higher intake in some of the more secure settings like hospitals, which again, only poses to have a much more and greater recidivism. So those are the key points. I know a lot of those you've heard this discussed from an ASO perspective. Having those in conjunction are necessary.
Absolutely, Justin. And I'll just say, when we take a look at that continuum of care, this is not like the one thing. This is on like what is missing that we need in our state, which is a facility type that's missing, and can it provide a need that's not being provided other places. And the hope really is the people who do have those comorbidity issues, who need hospital care, are the ones that are going to the hospital, and someone who doesn't is able to come to this facility. So really it is about trying to send people to places that are appropriate for them, instead of, the option right now, again, is emergency room or jail. And so I hear you on that. I think a lot of us do, but this is really meant to be one spot with all the other supportive services that you mentioned also there. It's not in lieu of, it's in addition to. And it's always going to come down, unfortunately, to the workforce issue that Rep. Davis can chime in on, and trying to build that and see what that looks like. But I hear you on that. Jennifer Stewart.
Hello, I think it's the lowering the hand and the mute button. That's the two-step process that's a bit challenging. Thanks so much. I wanted to just remind folks, some of us were in Arizona, and the fact that peer respite center was just so close, and it was on the same premise, and that tie-in there was huge in terms of people being able to transition to that space if they couldn't leave in that time period. When I hear the term, the state will pay for it, I don't really know what that means. It makes me scared that that isn't sustainable funding. I don't know what it means. Does that mean that Medicaid managed care is going to be chipping in a way that they're not now? Does it mean commercial payers are going to, I just don't know what that means. So yeah. I just am worried about the financial underbelly of everything we're talking about. And then that's going to be my repeated comment. And then I think the last thing is when you say the state's going to require it, I don't know what that means either. Like, does that mean the BHASOs are going to be making sure that the state requires it? Or does that mean the state literally, I just don't know who's going to make sure these mandates are actually, people are actually accountable and that the system is transparent.
So this is where, when I say the state's going to pay for it, if we're saying that it's going to come from general fund dollars or a specific state budget, then we can do the mandates on if you want these dollars, you shall have. And so for this facility type to receive the funding that the state's going to provide, they're going to have to do the 23-hour crisis. They are going to have to accept everyone with very, very limited exceptions. They're going to not require medical clearance, all that kind of stuff. And we're happy to send the bill out on the language, and that'll have this information. But to your point, Jennifer, this is exactly like the Arizona model, basically. It is those 23-hour facilities, and that is the point of also saying, have that relationship with other resources where you can then try and do that warm handoff to someone else. But we are trying to get creative with the funding model because we don't want things to fall out. So often the state will say they want X, Y, and Z, but when you look at implementation, only the Z is there and the X, Y is missing. And so this is our attempt to say the state wants X, Y, Z, and the state's going to pay for X, Y, Z. And if you don't provide X, Y, Z, then you may not get the funding, and you'll have to do, be a crisis stabilization unit instead of the 23-hour crisis unit. So we're trying something different, and we're trying to see how we can actually get what the vision is. Megan, and I think we may have to move on to the next.
I have a comment too before.
Oh, sorry. Go ahead.
Do we have a sense of the capacity of the resources to pass people off onto, so we don't create an upstream resource that we then can't fully utilize? Do we have a sense of that capacity?
I don't know if anyone has the answer to that. I think when there are people who are interested in doing this work, they are going to have to reach out and build those relationships before they ask for these dollars, because they will be asked to show that relationship to provide that warm handoff. And so I think many times when you put these dollars out, you get a lot of information back, depending on how many people are going for those dollars, accepting those dollars. I think the fact that King County has already said they're going to fund 5 kind of similar sites. I think we'll just see what feedback we get on this. And any of the providers, feel free to jump in if you would like to answer that question. I know Rep. Orwell has some thoughts too.
Well, I did visit the RI facility in Pierce County, which operates a lot like a 23-hour facility as far as the no wrong door in the medical. And so it was interesting to see how, and what they think are some of the Washington barriers around the medical clearance and the comfort of EMS bringing people to that facility. The other thing that I think around funding in the 23 hours is we're realizing the state is going to need to be a really good partner, especially on capital budget. There's not a lot of places for people to go to get additional capital dollars. So we really want to work with our colleagues to see if the state couldn't be doing bigger investments on the capital budget front.
Thank you. Okay, I think this is taking us to the next. So we'll send a bill draft out. And then again, people read it, edit it, send information, email us your thoughts on it. This is the time to make sure we are incorporating all of that. And then, of course, this takes us to the workforce issue. Megan, was that the old hand, or did you want to add something? Okay. To the workforce issue. Again, this is where any and all ideas and suggestions are highly, highly welcome. We've heard about doing more around loan repayment. We have heard people talk about creating more flexible schedules. We've heard from people that we really need to do something to consider experience in lieu of education. I think especially when it comes to crisis work, people want to take a look at credentialing, they want to take a look at supervision hours. And the thing that I and others feel is really something that our state can do better is creating more of a peer workforce. So I want to turn this over to Rep. Davis, who actually has a bill on peer workforce. And I'm very optimistic that we can pass it next session. But if you can walk us through that, Rep. Davis, that would be great.
Sure. Yeah, thank you so much for the opportunity to be here. So just at a really high level, just to zoom out for a second, I apologize for the repetition. I'm sure many of you have heard my spiel or heard me talk about this topic, but you know, globally, right, we're facing a tremendous behavioral health workforce crisis, and peers are really unique in that, in the sense that they're really the only profession in the entire workforce sphere where we actually have a surplus rather than a shortage of willing workers. We have tons of folks. I mean, ACA has done a really commendable work to bring down the wait list, but we had 1,200 people on the wait list for the peer training, and why that's instructive as it relates to this is that you got 1,200 workers saying, I want to do this work, but there's actually a lot more than that out there. People with lived expertise who are working in other industries and would love to lend their talents to this. So the bill that I have, it was House Bill 1865 this last session. It will change numbers because every 2 years we recycle the bill numbers, so it'll have to get a new number, but it's essentially trying to solve two primary problems. And those two primary problems were created by the same issue in statute. So there is a part of statute called Title 18, and that houses, it's like the big book of health professions, right? So acupuncturists and physicians and nurses and any other type of health profession. But curiously, peers are not listed in there. And there's some somewhat sordid history that I won't go into about why. But essentially, Washington state law doesn't recognize peers as really sort of a legitimate health profession alongside every other health profession, which in and of itself is problematic. But the fact that peers are not in Title 18 creates two primary issues that this bill would address. And what the bill does is it essentially puts peers into Title 18, so they're their own kind of freestanding health profession. But the two issues are, number one, commercial carriers, so the Regencies and Primeras and Kaisers and those insurance carriers can only bill for services provided by provider types listed in Title 18. So what that means functionally is that every individual in the state of Washington who has commercial coverage, which is a lot of folks through their job, through their parents, young people up to the age of 26, approximately 50% of the children in the state of Washington have commercial coverage. None of those people can access peer services. The miracle and the magic and the recovery and the sustained disease remission that can be found in peer services, they can access absolutely none of it, which is bananas. And I've talked extensively with the carriers who are interested in engaging with this provider type, but they literally can't until such time as peers are recognized in Title 18. So that's problem number one. Problem number two is where peers do exist is this very sort of curious, nebulous place where they're designated as agency affiliated counselors by the Department of Health. And the way that agency is defined is it's a community behavioral health agency. So if you are a peer who works at a healthcare entity that bills insurance, such as an emergency department, primary care, urgent care, it's bananas, but you can't actually bill for the peer services because they're not in Title 18. Because why? An emergency department, primary care, or urgent care is not a community behavioral health agency, and the definition of agency affiliated counselor is so limited. So that's really what the bill is trying to solve. And the bill was drafted exclusively by peers with a tremendous amount of meetings and stakeholder input. We've amended the bill significantly over the last couple sessions with feedback from other peers. I would continue to welcome any input or suggestions, but really what we're trying to do with that is create a career ladder for peers where peers can actually supervise peers, which is not currently an option and is really, really important to kind of preserve everything that makes a peer, and also to again, provide the opportunity for peers to work in so many more settings than they're currently able to work, and for so many more people who currently can't access peer services to access them. We know that, peers can't sort of fix the totality of the behavioral health workforce crisis, but they can actually play a huge role, but only if we let them and remove these sort of artificial barriers that have been erected in statute. So that's really the essence of the bill. Happy to answer any questions that folks may have, but appreciate the chance to talk about it.
Thank you. Questions, comments, thoughts? And we can send that bill draft out. Sure, Huck?
Yeah, I'm excited to hear about this happening. I'm curious, something that's been percolating in my brain has been relationship between the peer role and the home care aide care provider role. When we did our tour of some of the crisis system options, there was some conversation about like the role that maybe a home care helper can be in assessing people's mental health and supporting their mental health.
Yeah, that's a great question. I'll be the first to admit, I don't actually claim much of any sort of expertise in kind of the home health aid sphere. I mean, I serve on the healthcare committee, so certainly that's within our committee's jurisdiction, but I would candidly and welcome other people who might have a better answer. I do think I love the concept in general of thinking about other professions that are not necessarily traditionally considered behavioral health professions, so to speak, and thinking about how can we lean them in and leverage their skill set for behavioral health. There's been talk about occupational therapists, for instance, and how could we leverage that professional group for behavioral health. So to that extent, absolutely. And yeah, would welcome further conversation.
Michelle?
Hi, everyone. Michelle McDaniel. I'm the CEO of Crisis Connections. So first of all, I really appreciate the focus on the broad provider types. We absolutely need that. And so thank you, Rep. Davis, for your work on this. Super important. And I want to speak more broadly as well around the fact that, among the provider types that we also need to have, required to have, and should have are people who are licensed clinicians. And the number one issue, not just with licensed clinicians, but across all provider types, has to be a focus on increasing wages. We know that when people go into Health and Human Services work, they take a wage penalty. And that is something that is across many different components, from childcare to home nursing and so forth. So I can't, reinforce enough around how great it is to be able to talk specifically about loan repayment, opportunities for career advancement, covering licensure costs and so forth. But the bottom line is, not only are we losing people because the work is hard, it's taxing, but we have a lot of competition even within behavioral health for other positions in hospitals and so forth that make it really difficult for us as frontline providers of the 988 system, the regional crisis line and so forth, to even be able to compete with other positions within the field. So raising base wages just is a have to, and the real cost of doing this work includes living wage. So I just want to put a big plug into that. I'm sure that's not a new idea, but that is the number one issue when it comes to trying to attract and retain staff. The other is whatever systems and input we can get to try to attract BIPOC providers. We just do not have the representation in all aspects of behavioral health for who we are serving in the community, and for people to be helped and serviced and supported by people who are part of their community in every aspect of that. So any ways that we could be able to reach out and have partnerships to find out how is it that we could be better employers, better at attracting and retaining BIPOC communities is also a huge area of focus that I think we need to lean into. Thank you.
I know Rep. Davis has an answer to or a comment on the BIPOC workforce. I'll let her go.
Yeah, just briefly, thank you for that comment. So really within kind of the peer context, so I had a budget proviso a year or 2 years ago related to recruitment of BIPOC peers. So not only, our peers, that area where we have a surplus of willing workers, but it's also the area where when we talk about sincerely wanting to have our behavioral health workforce reflect the communities being served, the part of the behavioral health workforce where we can do that most quickly is also peers. And that is because of the training being more truncated for peers. And so you can actually sort of create behavioral health workers that are trained up more quickly. And there are certainly lots of individuals, BIPOC identified individuals who've been impacted by behavioral health and substance use challenges. So to that end, there was this pot of money given to the healthcare authority, and they put out an RFP for recruitment of BIPOC peers, and they had a ton of applications, which was amazing. And so there's all these different, I don't know if anybody from HCA is on here and can talk about it, or maybe they can be invited back, but there's a ton of creativity and ingenuity and innovation that was a direct result of that, and different ways to actually help different BIPOC communities understand what the peer profession is and try to get people into those trainings and mentor people into that workforce. Theoretically, you could do something like that across any profession, but we happened to sort of try that or test drive that in the peer space, and I think it's been tremendously successful. So, and I apologize, I have to go, but thank you so much, everybody.
Thank you for that. And again, to put that much emphasis and support as well into positions that are bachelor's level, licensed, so forth, would be great as well. So I'm encouraged by that. Thank you.
Thank you. And before we move on to Rep. Orwell, I just want to say I put in chat Rep. Davis's bill along with her email. Sorry, Rep. Davis, oh, she's gone. There was a request to have her email so people can communicate with her directly. And the other thing I put in chat is a bill that Senator Trudeau had last year on establishing a behavioral health support specialist position. So that's there as well. And I'm also always happy to take feedback on any of these bills. Rep. Orwell.
Thank you, Senator. And this is a great discussion. I know when we did the 988 fee and the call centers, we did try to put in dollars to allow for higher salaries. Again, kind of, I know it'd be nice to magically increase everyone's salary, but it's nice to start where we have some new resources. The other place seems like the behavioral health certified clinics really provide an opportunity for a higher rate of Medicaid reimbursement. So I don't know if there's any updates. I think there's a grant application out. I don't know if our state's going for that. And then I'm also working on the social worker compact bill and how we can have more professionals come into our state more rapidly.
Thank you, Bipasha.
I know we've been talking about this. I just want to mention it officially. I learned about this a while back through Crisis Jam when they did a survey of the Georgia crisis service providers. And they did talk about having better pay, which we all have been talking. But the one thing they also said is, in addition, they need to not be overwhelmed with the work, because no amount of pay is going to make up for having to work long hours. And crisis services is a little different than other behavioral health services. And as such, in extension, also to consider ongoing training and support around secondary trauma. So that's really important. And that comes from the behavioral health practitioners themselves.
And thank you for that, Bipasha. And I know Rep. Orwell is nodding her head because we've been talking about getting dollars made available or programming made available to address secondary trauma. And this actually takes us literally into the next segment, which is actually going to be liability, but maybe we can switch it up and talk about the training and resources for crisis responders, Rep. Orwell, or however you want to do it. But
yeah,
let's
I think
segue into that next thing.
I would be happy to jump into that conversation. And I remember a couple of years ago being in a room with about 25 or 45 social workers, and I asked, how many of you have the skills to work with people that are suicidal? And how many hands do you think went up? 3. So I think social workers and people, anyone working in this profession, not only needs the support, but we need to make sure we're giving the training so that they feel like they have the tools and skills they need. So there is a component of the bill I'm looking at that would provide training, and we're looking at maybe having it like regional trainings, where maybe that would be first responders. You'd have your 988, your 911, maybe your EMS, your rapid response teams. Like, is there a way we could do some of this training together? I do have a list of some of the ideas that have come up, and I'd like to hear more today. Suicide assessment and safety, trauma-informed practices, secondary trauma and resiliency, 98 resources and community resources, cultural competency, best practice approaches working with veterans, best practice approaches working with individuals with IDD, best practices working with LGBTQIA. So again, I think we're trying to figure out, if we have this crisis system and we're expanding it, like what are the core competencies that they should be receiving? So I would love more feedback of what else do we need to capture, or some of these need to be prioritized.
And I'll just add, when they mentioned the LGBTQ IA+, I think there's more of a stress on that for our youth and people who work with adolescents, given that. I mean, obviously the training should be across the board, but I think a special emphasis and focus on that, given the disproportionate challenges with mental health and that population. Claudia.
I would just maybe a follow-up with the comment that Michelle made before. The bicultural individuals, the people who come from other cultures, it's just not only getting training on cultural competency, is we need to make a very clear and intentional effort to bring people in the field who are bilingual by culture and they're also licensed. They are available. I just brought 22 people from out of state. And I made all the efforts with the Department of Health. I helped them to the licensing. So there are people out there, but we have to make a very intentional effort to be able to bring those to work in the crisis centers. So I think it should be a subcommittee. There will be something that we focus about how we really make sure the all crisis centers have people who speak Russian, Spanish. I mean, that has to be very intentional.
That's excellent feedback. Thank you, Claudia. Other thoughts on the training component? What do folks think about the idea of regional trainings and bringing different first responders together? I'm looking at my 988 call centers because I know you're part of it.
I'll just jump in and say that I like the idea because I think there's so many silos of people working. So if they can train together, I think they can be more informed about what each other does, and also develop some collaborative ways of dealing with the process. So I like the idea.
Excellent, thank you. Adam?
I just want to point out that, any training that happens needs to include 911 telecommunicators along with it, and any co-training we can do is the best. And because we're still taking those, we're still taking suicide calls, and we'll continue to. So we need to make sure that we're all on the same page training wise. So anytime you can include us in any of those bills, we appreciate it.
And you are. The first responders would be 988, 911, EMS, and the rapid response teams. And again, I'm thinking about 23-hour facilities. Like, who all do you bring in together? Kashi.
I'm always going to vote for youth-specific training, and thinking too about how to support. I think one of the things that's lacking is when you work with youth, you also have to work with the family system that they're in. And so a child in crisis is going to mean the family is experiencing some level of crisis as well. And so, ideally, probably adults would be supported by the family or family of choice around them too, but for youth specifically. And then this is a less well-formed thought, but I think in response to the point about silos, one of the things that I hear from our frontline team is when you are on the front line and you have the most intensive job, like the crisis responder, not seeing the bigger picture or not being able to have access to even the information about the improvements that are being made is really discouraging. And I think it's contributing to burnout among our frontline workforce, that if you feel like you're doing the job that's bailing buckets of water out of a sinking ship, and you don't know that somebody's on the outside trying to patch the ship and keep it afloat and move it in the right direction, that's a very hard job to continue to show up to do. And so I think it's more than individual self-care. It's recognizing that there is a lot of improvement work happening. How do we give everybody access to that information so they know it's going to get better and it's not always going to be this hard?
Good feedback. Thank you so much. Jen Stuber.
I just wanted to raise the
the needs of fire and EMS, who are, you know, increasingly going out to crisis related calls. 18,000, I think, is the number of fire and EMS, and the hunger for training amongst this group is huge. And I worry a little bit about, I'm excited about the cross training idea, but I also have been to some trainings for fire and EMS that the fire and EMS can't see themselves in, because there is a unique culture. And I think there's a need for like if you're going to do a training, for example, a CIT training with fire and EMS, for fire and EMS, that you actually really are representing that culture and the specific unique needs that EMS in particular can play on these teams. And I think there's a need for, you know, kind of basic level training around, you know, crisis de-escalation and doing that well. But then I know they're really interested in some advanced training, CBT for psychosis, a lot of more deep training on advanced substance use. I'm seeing a desire for, you know, some reworking around protocols and policies around suicide, around substance abuse, and then that needs to get integrated into the training so everyone's on the same page around what we're actually doing at a state level. And so I like the co-training idea, but I also really think you have to adapt training to the audience. And I know you know that because you worked on so many training bills. Yeah.
No, absolutely. And I think that's why you're going to need a pretty seasoned team to help develop it, because there's areas where it can be overlap. I was just really impressed when 988 and 911 and everyone was in the same room, because they also need to really understand each other's roles and how to work together. And so, you know, maybe there's portions that are overlapped and portions that aren't. But I appreciate, how do you get everyone to attend? And how do you make it so it fits for their work? Thank you. Darcy.
Hi, you know, a group that I would like us to put up for consideration are our emergency room staff. They really are the ones that, when all is said and done, if this system works the way it should, we'll be still taking care of people that are truly in, you know, psychiatric emergency and crisis. And
yeah,
so if we can just add them to the list, that'd be great.
No, excellent point. Thank you so much. Puck.
Yeah, I was just gonna message Tina and then I was like, I'll say the words. So I feel like we aren't communicating well with the public. The bailing the boat metaphor. We're not communicating well with the public, which includes ourselves, which includes providers. I mean, a bunch of us don't know what's going on with other people. So how can we expect that from the general public as well? So I encourage everyone who's developing anything to make sure to put some money and effort into outreach as well.
Thank you. That's a great feedback. Any other thoughts on the training component? Jen.
I'm sorry, I can't. I also have to say emphasis on evaluation and making sure the training is actually working. One and done models don't work very well. We know that. You need to kind of re-emphasize simulations, scenarios, that kind of thing are all really important.
Excellent. Thank you. Anything else before we move on to the next topic? Okay, Bob.
Just for those of you who don't know, my name is Bob Graham. I'm with the Criminal Justice Training Commission. The way we have state CIT training set up is it's regionally specific. So you can put models and resources from that region in the specific 40-hour program. So say it's in Pierce County or it's in Moses Lake, you can put those resources for the first responders in that 40-hour training. That's, you know, that model is already set up. We also have been doing some 8-hour CIT trainings exclusively for fire in EMS. And those have really taken off because they don't have a lot of training in those areas.
Thank you for sharing that. And it seems like you very knowledgeable in this arena, and we should work with you. Thank you. Any other thoughts on the training? Again, that will be part of the bill next session. And think next up is liability. This is an exciting topic. So we want to make sure, and I don't know if Chris Blank is on with us today, but he did some work really looking around liabilities protection for 911. And we really realized that, you know, as our system in 988 grows and interfaces with 911 and dispatches crisis, rapid response teams, that we need to be looking at the liability or some kind of umbrella over all these parts of our system. And so Chris has been working on language that would kind of extend the 911 liability protections to 988. I think part of what will need to happen is some kind of protocol that would be developed by 911 and 988 that would then go to our state agencies for approval, and then that would kind of kick in the liability protection. We're also thinking that's needed for the rapid response teams that work with 988. Again, we're hearing other issues that are coming up with local jurisdictions. Maybe I'll let Senator Dingra talk about that. But we want to make sure that as we're kind of building the system that we're expanding protections. And of course, there's exception for gross negligence, and we're looking at what the exceptions are, which are probably similar to the 911 system. But Senator Dingra, do you have any comments?
Thank you. Yeah, we do want to make sure that people who are doing this crisis work do have liability protection based on the decisions they're making, whether to send a team out, not to send a team out. There are always, you know, gross negligence is, you just can't, you can't protect that. We do expect people to be competent and do their job by following the protocols. So having underlying protocols is really critical in making sure that you're holding people responsible to those protocols. The other thing we heard, especially when we went to Kitsap County, is actually how do we make sure that our cities who are doing this work and stepping into this work can get liability protection. And didn't realize that was an issue until we heard from Polsbo, I believe. And then recently the city of Kirkland was actually able to make some changes to the insurance pool that many of these cities participate in. So that's an issue that we heard on our tours around the state. And so we're going to be taking a look to see how we can fix that so that more people who want to get involved in this work can do this in a way that they feel that they're protected.
Thank you. Any questions or comments on this component?
People rarely want to pipe up and talk about liability, but if things do come to you, please do let us know.
If there were more attorneys in the room, maybe we would. No, that's good.
I would say the liability of the provider is really important, but at the same time, the safety of our patients. So looking at a both perspective, right? Liability of the providers who are there, but at the same time, how we create an environment who is very safe to the patients that we serve. We're experiencing in a youth facility currently a lot of issue because there is many gang members who are coming. It's becoming very difficult to maintain safety of just the kids who are there because there's so much infiltration right now, different gang rivalities. That's becoming really interesting on how to protect the patients who are in the facilities. So I think liability comes from, has two sides, right? Liability of the provider, but at the same time, safety and protection of the clients that we serve.
I appreciate you raising that, Claudia. And if you have other thoughts of things we need to do, I think you raised a really important point that we haven't talked about in these conversations. Other comments on the liability before we move on? We'll have some language to share. I know we'd like to, it's still in draft and that will be provided to the group as soon as we have a final draft. And there's a little work group that's been trying to kind of come up with the structure of it. Anything else on that? Okay. I think we talked about workforce training, rapid response teams. And Nicola, I don't know if you have that one slide I sent you at the very last minute or not.
We do have that slide
Oh,
up on the wall,
thank you.
and I'm just gonna ask my colleague, Brittany, are you ready to share slides?
Yep, I'm pulling it up right now.
Thank you.
Thank you. So the rapid response team, I just want to kind of take a moment on this. For me, it feels like 988 will never truly be a partner to 911 unless we have the ability to rapidly respond to what probably is a very small portion of calls. We know the call centers, and I hear anything from 85, 90% of the calls are resolved on the phone. And obviously there will be protocol for those that are very urgent, emergent for 911, but we do want that ability for a 988 call that does need a response within a very short duration. I think we're still trying to find what that looks like, you know, and it probably looks different in urban areas than suburban, rural, and frontier. And in fact, our laws on the 911 system have different criteria in different parts of the state. And it's usually written like up to 80% of the calls will be responded to within like 20 minutes. And so we don't know exactly what the right language is. And we also realize that we want to set up the vision, and it's going to take time to get there. And so we like to define what a rapid response is. And, you know, maybe the state can have some dollars. We do have some of the telecom dollars for areas of the state that would like to really kind of create the rapid response teams. Again, we want that really to have a strong clinical focus, have someone with lived experience. The other thing we saw when we were in Arizona for their 23-hour centers is that 80% were taken in the back of a police car. And we think that's very triggering and traumatic. And so as we think the rapid response teams, we'd like to think about alternative transportation. You know, in some areas, maybe that's a partnership with EMS or fire. Maybe in some areas that's vans. You know, all of our system may look different in different regions, but we would like to kind of talk about what this rapid response could and should look like and how we move our system forward. So I think you can kind of take down the slide, and I'd love feedback. Ron.
I didn't say before, Ron Harding, I represent Washington Association of Sheriffs and Police Chiefs. And why were they 80% in law enforcement vehicles? I assume they were driven by law enforcement officers.
Well, what I heard, and there's a lot of people on this Zoom that were part of it, was that it took 40 minutes, an hour, 2 hours for behavioral health to show up. And so that's why I think that behavioral health in our rapid response teams, and they may be partnered in all different ways, including with EMS, that they have to have that ability to arrive more rapidly and have some ability to transport. If not, the default tends to be the police, is what I heard. Anyone else that went to Arizona want to comment on that?
I agree. I think it was just a lack of resources to be able to have a non-police, non-law enforcement ability to get there. And I shared the same concern. I think a lot of folks who did go on this trip shared the same concern that Rep. Orwell is talking about, that there was a much higher level of representation from law enforcement doing drop-offs than we think would be healthy in the system. So this is a great alternative to be able to ensure we're not relying too heavily on law enforcement to do the pickup and drop off.
Was it due to the initial response? The call was not made to 911. I think it was made to a different system in Arizona.
Well, you know, they have
law enforcement responded, or do we know?
Well, you know, they have an interesting system because some of us also went to their call center, and they have more of a regional call center that's probably more grounded in 911. And they do have some mental health, like a social worker there for consultation. So I think they lean in more to their 911 system in Arizona, where I think we're hoping for behavioral health to lean in more to our 988 system. But I think you're right, Ron. I think that was probably part of it as well. But, you know, again, you know, trying to figure out how we can respond as much as possible to the 988 calls, I think is hopefully the goal of our state.
Yeah, I guess, and the criteria will be important to establish which field response you send. And that's, as you already know, you know this well, that's a difficult thing to discern, given the stimulus that comes over the phone line. I mean, you don't exactly know. So fluid transfer between those systems is important. And, you know, I know you've heard that before too.
Well, what struck me, and I hung out with 911 the other day at South Sound, and you know and Adam's on this phone it's a dispatch is a quick model, right? They're making maybe a decision in 120 seconds, and they get a lot of mental health calls. I can tell you, when I was there, they got a lot, and I think you're right. I think that's just, you know, 988 isn't a dispatch system, right? It's a clinical intervention that could lead to a dispatch. So I think even trying to get the calls to 988, you know, we're also doing some potential co-location to try to figure out those protocols, like when calls need to go back and forth. But I think there's probably a number of calls that go into 911 that ideally we would want in 988, especially when our system is functional. Adam, do you want to add to that?
Yeah, I mean, that's gonna be the challenging thing, because so many of the calls we get in dispatch for, yes, mental health is a reason, but there's also an associated reason, like the person's walking around with a knife or a gun or something like that. So the ones that could clearly go over to 988, that's always the challenge, because we're trying to dispatch quickly. So I think that's where not only the training, but also the liability piece lies in there. And the procedural piece is, are there times when 911 will continue to dispatch co-response teams or possibly DCRs until the 988 system is up and really fully running, to where we can just transfer those calls? So the amount of calls we are able to, as some people say, skim off of 911 to go to 988, that is going to be a challenge, and going to take a lot of looking into. And that's where some of the co-location situations we're looking at South Sound and at Valleycom, there I can see it, because handing a call off to someone who's listening in right next to you or looking at your CAD system and pulling it off is much easier than break and passing that call over, especially when we don't have the technology right now to do some of the transfers we would like to with information wise. That makes it a challenge. So I don't know if that answered the question or just gave more questions.
Thank you. Ron, did you have another comment? No. Other people have comments on the rapid response? And again, I mean, the vision is that it's clinicians, that we're not like rapidly responding our DCRs, that we're not the going, and that it would be people with lived experience in behavioral health really making those connections whenever possible, and that our DCR system would be kind of the side system, right, which would be more through our regional call lines.
Jane, you had your hand up. I wanted to make sure you got an opportunity to say something.
I saw Bipasha, and who else?
Yep.
Oh, Jane's had her hand up for a while.
Oh, and Jane. Okay, I'm sorry.
No, don't worry about it. So I was going to mention, Senator Dingler, this was at the NASHB conference. There was a really good session on crisis services in remote and underserved areas. I don't know whether you had a chance to listen in, but Oklahoma's model of that partnership with the local sheriffs. And they actually, through, I can't remember whether it was 1115, I think it might have been through an 1115 waiver, they were able to fund transport that's non-law enforcement transport using DCRs to services. So I can try to get the presentation from that and share it with you, Representative Orwell.
That would be excellent. Thank you. And when I was in Ireland this summer, they had ambulances that were for health and mental health that, you know, did not require, you know, kind of a full EMS. Bipasha.
Are you using this term rapid response equally with the mobile crisis team? I'm a little confused about whether it's different, similar, same.
And I think that's an excellent question. And I was working with others trying to come up with terminology that would be unique And I always think of Senator Dingra's little flow charts when we were working on 988, because 988 in the fee is not to their ability to fund the whole behavioral health system, right? It's really tied to the 988 calls, and even that rapid nature is tied to the 988. And so the term rapid response team is really to try to have a narrow carve out for 988 calls and calls that require a more rapid response. And so we're trying to not use terms we use in other areas and come up with kind of a unique term. And then again, as we move forward and we try to get funds to maybe have some areas really test these models, then we can use the 988 fee. Senator Dingra, do you want to add anything there?
Sure. So, this is, and I'm so glad you asked that question, Bipasha, because I know Rep. Orwell and I had a lot of conversations about this term. And when you asked the question, I'm like, oh, I don't think Rep. Orwell explained the term. So that was perfect. So, we were one of the first states to do a fee to 988. And so part of the bill process around that fee, it says that we cannot use that to supplant services that already exist. It can only be for new services that are related to 988. And it was very much about just for that crisis. And so Rep. Orwell mentioned a flow chart. I love flow charts. I think it helps explain complex things in a way sometimes that's helpful. And so in that flow chart, I had said, fine, we'll use the 988 fee just for the 988 call, but having a rapid response is a resolution of that call. So this very specific term, rapid response, is affiliated with the call because it's a resolution of that call. And so it's a service we can use the fee to provide. We cannot use it to provide things that already exist, like the co-responder model or other mobile crisis units that already exist. So this is very much tied to the fee and is a way of resolving that call. So and that's why we have been working on a different word to just make sure people understand what it is. And also, this goes back to there are a lot of people who've been traumatized with the system in Washington, and I think there are phrases and words that people may have a preconceived notion on what that would look like or what that response looks like. So this is also an attempt to say we are doing something different, we are doing something new, and we really want to be as trauma informed as possible. And so that's why this word is here. And this goes back to also the facility type, being very deliberate about the words that we're using for that facility type. Is the same thing, because we are creating something new with all of your help, and really making sure we're identifying that as this new thing. There are some great things that already exist. We're not saying we're getting rid of any of the great things. We're just saying that fee can only pay for this new thing. It cannot be used to pay for all the great stuff that's already happening.
Well said, thank you. Other comments or questions on the rapid response teams? Yes, Megan.
So just to clarify, it's a funding source
yes.
Designation. Okay. Because I think in the field, it's going to get really hard to be able to determine what calls coming into 988 or RCLs end up to which type of team. So I think we just want to think about the implementation of that and what it looks like. So
yeah. That's a great point. And again, I think it's going to be the source and the expectations, just like it's different on the 23-hour. What will be expected, there'll be some differences on the expectations of the rapid response teams.
And this is where the rural-urban differences also come in. I think we heard very clearly, even from Kitsap County, but that that fire in that area really wants to get more involved in this work. We've heard from other areas where the behavioral health agency is really involved, is ready to get involved in this work. And so each region is going to look really different. And so creating that flexibility to make sure that there is, that each region is served according to the culture, the resources that exist there, making sure we have statewide metrics, right? Because we want everyone to have the same access to resources and care across the state, but really making it, giving that flexibility to make it very particular for that region.
Yeah, thank you. And I'm also working with Representative Brownski, really looking about, and of course, Senator Dingra, around can we help fund some vans? Can we help provide some vehicles that rapid response crisis teams could use, or other entities, as a way to kind of get our system more quickly up and running with alternative transportation? Anything else on the rapid response teams? See any hands? I think the last category was like other, where we just kind of open it up. Is that right, Senator Dingra?
That is, I do have a category of other that we have talked about, but I wanted to call it out, and that's transportation. Rep. Orwell has mentioned it, others have mentioned it, and I'll say, I am not sure any one of us has a good solution to this, but we have heard for years and years and years that there is a huge need on how do we create transportation for people to get from point A to point B for treatment. This is true like across the board. And anyone? And I look forward to what Jane's going to send us from NASHB on that presentation.
Anne has her hand up.
I don't hear her. Roxanne?
I said it's really confusing for the paratransit because you have 2 weeks in advance, and half the time you have to wait on hold like 3 hours. And then like paratransit, you have to do 3 to 5 days. And it makes it really difficult and stuff because like you have to plan around it, and paratransit keeps you on the line for like an hour.
Wow.
And that's not beneficial. And so yeah, and you know, sometimes you can't get a hold of them, and if you don't get a hold of them 2 days before your appointment, you're screwed.
Mm-hmm.
So yeah, and then I just wanted to tell Kashi, thank you for, I don't know if she's still on, but I have autism myself, and I really appreciate her advocating for people that have disabilities with autism and DDD.
Thank you.
But yeah, I feel like there needs to be more transparency in the transportation, and they need to fix it so it's not so stressful.
Thank you. Appreciate your comments. And again, we'll open it up for any CRIS members that have additional issues.
No amazing solutions from anyone? Okay, Michelle.
I was going to move on to other topic.
Sure.
Go ahead. You got me all excited. I'm like, there we go.
Maybe in that period, somebody will come up with a great solution. I don't have one for this problem. There's some conversations coming up soon to talk about 211, so other dialing code, and 988. So I just want to put a plug in around, I think this is an opportunity for us to figure out how to collaborate and integrate with those two systems, because 211 also has been under resourced, and I think we really haven't leveraged it in the state as well as I think we could. And it really is a prevention and a postvention opportunity as well around behavioral health and the 988 work. So I just want to put a plug in there that I think to broaden a little bit more and see how we can really lift 211 to be part of this system would be really smart of us, including a really deep and accurate resource database around behavioral health resources that we are lacking right now as well.
And I appreciate you bringing that up. I'm looking forward to our meetings coming up, and I could almost see, and I don't know if you think, Michelle, that there could be some protocol when 988 hands off to 211. Like there may be people that clearly were looking for the 211 line. What are your thoughts on that?
Oh, absolutely. I think we experience that now with the RCLs and 988, that you know, there's different, again, it's an opportunity to standardize what happens within all three of the 988 call centers, because we also happen to be 211 call centers operators as well. So I think that, again, I think we're right to prioritize 911 and 988, but I think this is the next opportunity for us to integrate those more and standardize what happens, and to look at how we can strengthen and build the 211 system.
Thank you. Appreciate that. See a lot of heads nodding.
So I know the other thing is something that has been mentioned before, and that was the capital requests. And so we really do want to be deliberate about asking our capital chairs to make dollars available again for youth centers. I know we had done a few years ago, really made sure we had clubhouses available all across the state so that everyone has equal access to clubhouses. And then we're going to continue to work on providing more recovery houses. But I think in terms of capital, if people have other suggestions, ideas that they would like to see our capital dollars being used for, just let us know if there's any asks. And I'm just telling everyone, I think if anyone has or is willing to provide care and needs a facility, please let us know. We really want to be as helpful as possible and being mindful of siting issues or NIMBY issues and really trying to work through all of those, NIMBY being not in my backyard. So yes, Adam.
I was going to say we could build 3 joint PSAP 988 centers for the 3 NSPLs.
They all look like sound 911, right? Well, I tell you, having been to Spokane, there's and over to Everett, there is some very, and all of the call centers are all very lovely, the 988 call centers, and as they should be, a lot of natural light and been very well done. Good posture.
With regards to transportation, I've heard some stories from lived experience talking about how their counselor or peer dropped them off or picked them up. I don't know where that fits in, if peers fall into that role and liability around that. I have no idea, but if anyone knows more, if this has been brought up, if you could talk to it.
That's an excellent point. And as we're looking at liability, if we do add in transportation, we certainly should look at that too.
And that is a huge issue. And it's one of the barriers why people normally don't use their personal vehicles for transportation, because it comes down to if you're one person and the person next either sit behind you, do this and sit next to you, where they abscond in the middle of the transport. There are all kinds of issues around that. There normally are a lot of requirements that there be a barrier between the driver and the individual. Do you do secure transport? Do you not? So they're just very, very challenging. I know Rep. Orwell had this idea of like, was it like state bought vehicles that we just make available that people can use and drive them around? But there is a real concern on what this looks like and who's able to do this. I'll just say in my other job, there was a time when people were just getting like Uber to like take someone to inpatient treatment, and you really can't, because a lot of those drivers, if someone's not, and they're going to inpatient treatment, this is for substance use disorder, there's a lot of things that can go wrong. So we have to really think through who's providing the transport and make sure everyone feels safe.
Yes.
In that way.
Puck, and then I might call on Jan next. Puck.
Yeah, I'm also emailing, well, that thing I was saying earlier about like home care aides who are peer people. I think this is another of those intersections we heard at DESC about how much peer support is actually done in transit. And I think that that's another kind of like specific peer role we could in the future look at implementing, that is like, I am trained to be a peer, and also the specific vehicle transportation things.
Yeah, thank you. And DSC does that. They have their peers driving their vans. And I don't know if it's for part of their crisis work or just for transport for like appointments, but that would be good to check on. Jan, what is your perspective as an agency in the use of transportation? Do you guys have vans? Are you transporting?
For some of our programs, we do have vans. Sorry, I've got a dual thing.
Oh, no, sorry, I put you on the spot.
I know Frontier gives out bus
So-
passes for some of their programs, I think.
We do give out bus passes. We also have vans for some of our programs, like our clubhouse programs. And then with our True Blood programs, we also have vehicles that we use because some of our programs take us to the rural counties. And so we were able to purchase vehicles in order to do that. And with our PAC programs as well, we have vehicles that we use to help us transport clients.
So when you think of the rapid response teams and like, you know, I don't know if your agency would respond, hopefully they would, but can you see that working within a rapid response model or a certain type of van or EMS or fire? Like, what do you think of that?
I could see that happening in with certain types of individuals. We'd have to be sure that our staff could safely transport people. If not, we rely heavily on our co-responder teams because the officer as well as the mental health professional from Frontier are trained together on best practices in working with people who have a mental illness or a substance use disorder or who are in any type of behavioral health crisis. So we always have that as a secondary backup to us. And even with our involuntary treatment transports, it is rare that it is done by law enforcement. It is usually done by ambulance, by the fire department.
Okay, thank you. Thank you for sharing that. Other comments, issues? Claudia?
Yeah, one of the biggest issues that we face at CMAR with the bands, we do have bands, and is that occasionally a lot of the people that we hire are people who had some kind of driving record. So it becomes very difficult for them, for us to insure that driver. And we pay very high premiums to be able to have those drivers, you know, being able to drive our van. So if there's any compensation that one day could be created for insuring the drivers, because we do have the vans, we have the cars that we use for mobile crisis, we use for DCRs, we use for our treatment centers to bring in people from detox. There is a lot of vehicles that we have, but sometimes the issue is the driver has a no acceptable record, and it becomes real difficult to insure.
Thank you. I appreciate you sharing that. Pasha.
I was just thinking a little bit more, you know, we're talking, obviously this is a crisis response. The space is about the crisis response system, but being on the crisis line, you know, every crisis doesn't look the same. People can be of very high acuity, but quite amenable to be transported, you know, and then there can be people with high acuity who you know, it needs more safety for the person actually to be transported. And looking at the crisis continuum, eventually being prevention being the, you know, hopefully the bigger part of the system in time, you know, in community centers, people are just driving their neighbors around. These small grassroots organizations are already doing that. So I don't know if there's a way to envision transportation in a tiered kind of way to look at, you know, acuity versus moderate versus low, kind of sort of look at that a little bit more carefully than just have this or that.
Yeah, and it seems like that's a good point. And your rapid response team would have to make those clinical judgments, right, about what type of transportation would be indicated. But I think you're right. I like your term tiered modes of transportation. That's excellent. We're still on the line. Is there any other updates? I heard a little bit around next day appointments. I don't know. I know we have our agencies, and Jane, is there any more you can share on that front?
So, I mean, we have two parallel efforts going on, both of which involve commercial carriers. So Matt Gower has been leading up the insurer provider BHASO discussions around next day appointments. And I know there's been some discussions there. I'm not sure if Matt's still on, if he wants to weigh in. I don't know that there's a full consensus yet. There's still discussions going on. I know both Senator Dingra and Tina, you were at the presentation that we did to the Joint Select Committee, and we are literally bringing two different cultures together. On the paying for behavioral health crisis services front, we have gotten incredible assistance from One Healthport, who is they facilitated a smaller work group of carriers, BHASOs, and providers that are now taking a consensus recommendation up to the full association. So all of the carriers, all the BHASOs. And we have seen really significant movement from all parties to try to figure out a way to make this work. There are still some pretty significant impediments. We have OIC because so much good energy has been going into this stakeholder discussion, this multi-stakeholder discussion, rather than immediately requiring all the carriers to go out and contract with all of the providers directly immediately, which would have been very, very problematic from both a carrier and a provider perspective. We have basically communicated to the carriers that they can file what's a sort of an exception request with us, so that we know they're still going to be covering the services out of network for these crisis services, but we also know that they're engaging in this discussion. And the principle behind it is essentially taking the way the BHASOs are sort of the middle person between the providers and the Medicaid MCOs, and trying to figure out how we adapt that to commercial health insurance as well. Mm-hmm. So we've seen real movement by the carriers, real movement by the BHASOs to step up and try to make it work. So still tough issues to deal with, but really pleased with how, in what good faith people are coming to the table to try to figure out a way to make this work. So,
well, thank you. Very complex piece, and I appreciate everyone's work on that. Thank you.
You're welcome.
And I just wanted to provide the context for everyone, if you guys haven't followed along. In the 988 bill, we required that come January 2023, just in a month and a half, that next day appointments be made available for people in crisis. And so I do want to thank Jane and all the work that she has been doing in making sure that we can actually do this. So because it's a huge lift, but I do think it's one that'll have such amazing results for everyone doing this work. So I really do want to thank you, because it's been an uphill battle, and I know both Rep. Orwell and I've been pushing at it. And we're just speaking. You're the one who's
I know
the insurance providers are doing all the hard work. So really thank you for that.
Yeah, well, and I will say contextually, the behavioral health crisis service provision actually came out of a separate piece of legislation that was passed last session to align our state balance billing protections with a federal law that had passed. And essentially that law basically says that behavioral health crisis services are just like a hospital emergency department. So when somebody needs services from a mobile rapid response team, or if they go to a crisis stabilization or a crisis triage facility, those services need to be covered just like a hospital emergency room visit would be covered. So I think California's legislature may have just adopted a provision like this, but it's pretty unique nationally. And we're fully aware of the fact that if we can figure out how to do it here, hopefully we can share that with other states as well, who might be interested in doing that.
Yeah, and that was Representative Cody's bill, and I appreciate you mentioning that. I mean, we really are leading the country with the work that you're doing, and I know it got a lot of national attention on the 988 jam just because, yeah, we're ahead of the curve. So very proud.
Hard work, but worth it.
Thank
And
you.
I'll just say it was Rep. Cody's bill, but I do know it was OIC request legislation. So thank you again, Jade.
Yes, that's right.
Thank you very
Well
much.
done.
We were super proud of how bipartisan that bill was.
Well, it's incredible. So I know, Nicole, is there no, did you say no one signed up for public comment?
Currently, no one has signed up for public comment. I've sent out a chat message indicating that if anyone would like to make a comment, any of our community members, to please send me a chat no later than 3:45. So I'll keep you posted. For now, let's plan on wrapping up by 3:48, but I'll let you know in 5 minutes, you might have an extra 10 minutes to keep talking.
So I'll just say that just tells me that all our bills are fantastic and no one has any other changes to make to them. But no, I kid, obviously. I just really want to thank everyone for this discussion and for participating. I know there's a lot of information that we threw out, but I hope everything you heard today was something, it should all have been familiar because, you know, all of this information came from the meetings we have been attending with all of you and across the state. So again, if there's anything that we have missed, anything that you think should be added, I did get some private chats with some other recommendations and I've been adding them to my Excel spreadsheet. But, you know, we're going to try to start putting bills together. And we can absolutely try to send bills as they are drafted out to this committee. And we're not necessarily going to do like bill drafting in this format. It's more on making sure that the concepts are out there, and then literally everyone and anyone is welcome to provide feedback on those bills. It is also important that if you really want to come testify on a bill or want to be more engaged on a bill, please do email our offices and we can make sure that once they're dropped, then we can kind of keep you updated or informed on its progress. Even if you don't want to testify, there are actually mechanisms where you can just sign in and show support. And it is really important to do that because a lot of the other electeds who aren't working on this policy area, they will take a look at that list and they'll say, oh, 50 people signed up in support and maybe 75 are opposed, and it gives them information. And so if these are bills that you think that are important, if you don't want to testify, absolutely make sure you sign in and show your support because it is really important to do that. And, you know, in the legislative process, there's always an opportunity to provide feedback and make changes. And so please don't feel that anything that comes out as a bill draft or even once a bill is dropped, that a decision has been made. It simply is a starting point. The first legislative hearing or the committee hearing is where, again, feedback is very important to be provided. It passes out of that policy committee. It'll go to a fiscal committee. It then goes to the floor, and then it flips chambers and does the whole process again in the other chamber. So happy to keep you guys all engaged as much as you want or as little as you want, but know that you should feel free to contact either of us or both of us at any point in time with any ideas, suggestions, changes.
Yes, absolutely. Oh, good. Well, it sounds like we do have some good feedback coming from the community. And again, I want to say thank you. This has been a great dialogue and look forward to continuing it as we prep for session.
You all have excellent timing. Well done. Just a couple of action items before we move into public comment. I have 2 people signed up for public comment. A reminder, Michelle, you're going to ask your staff to pull together the data on interpreter use per Claudia's request. And then a reminder for everyone to expect a draft of the progress report for 2022. I guess it's technically 2023 on December 6th. Did I miss any action items, Nicola?
That's it, Jamie. Just had to get myself off mute.
Great. So I have 2 people signed up today, Kristen Wells and Deb Blakesley. What I'm going to do is, as I always do, is put the timer up on the screen. And Kristen and Deb, when I call your name, if you could turn on your video camera and start speaking, I'll give you the 2 minutes to speak here. So bear with me just a second. So I share the clock. All right. So let's start with Kristen Wells. When you're ready, Kristen, please turn on your video camera and start speaking.
Hello, can you hear me?
Yes.
Okay, my name is Kristen Wells. I'm on the Lived Experience Subcommittee. Myself, my husband, and my younger sister all have mental health diagnoses that we're in recovery for. I'm also a social worker that provides after-hours mental health crisis services for a community behavioral health provider. So I kind of see things from both sides. And what I wanted to comment on was, one, I'm super excited about everything that everyone's talking about. I very much am familiar with the lack of services that we have, especially for mid-level folks who don't necessarily need inpatient, but are more acute than what outpatient providers are able to help with. So I'm super excited about everything that we're doing. One of the big barriers that I notice for stabilizing folks, and I thought would be relevant to the discussion of discharging from the 23-hour facility, is the lack of housing options. I see that a lot for our clients that are in an emergency room and we're discharge planning and they have nowhere safe to go. Maybe their home is unsafe, maybe they have no home to go back to. There's super limited diversion beds. So one of the big things to work on, in addition to mental health services, is trying to figure something out for housing for folks, whether that's more shelters, transitional programs, whatever options we come up with. I think that's going to be one of the biggest barriers for transitioning people out of any crisis services we offer, is where can we send these people where they can feel safe and secure and be able to continue their mental health recovery. Thank you so much for your time.
Thank you, Kristen. Next up is Deb Blakesley. Deb, when you're ready, I'll start the timer.
I'm ready. I can't figure out how to do the start video. It doesn't seem to be turning. Oh, there it is. I'm ready.
Great, go ahead.
Sorry, I forgot. I'm Deb Blakesley, and I had some crises. I was not into the behavioral mental health, whatever it's called, purview, but I felt like I looked for help beforehand and did not find it. I still have a feeling that under the what y'all are doing for CRIS is not going to have what I needed, that I could have helped myself much earlier so that I would really avoid the crises. And my focus is on prevention. I'm trying to write a book so that people can stay out of some crises. And this is a book that I would love to have had. I could not get into what limited facilities or whatever or programs were available in 3 of the largest counties in Washington state. And I think that sucks. So my focus is I would love to do prevention. And I know that's a really tough field for people to talk about, but I would love prevention anyway. And I guess for me, maybe I should get off this committee, and I would love to know how I can be directed where I can focus my energies on pushing for prevention so that there are no crises. That's my story and I'm sticking to it.
Thank you, Deb. Is there anybody else? We have a few more minutes left. Is there anybody else who would like to make a comment today? If you do, please send me a chat. We'll give it another minute here. Okay, see someone? Oh, and Deb, I want to let you know Carrie Waterland said you may contact her, and I'll send you that information.
Okay, thank you.
Anyone else in the community who would like to submit a comment today or make a comment today? I'm also going to send out an email. This is our email box address. If you have a comment and you would prefer to send it in writing, please send it to this email address. All right. Well, it looks like we're coming to the end here today. So Senator Dingler, Representative Orwell, thank you so much for taking over facilitation today. CRIS committee members, as always, thank you so much for your time and your contributions today. And then finally, community members, a big thank you to all of you for spending time with us today. Before we go, Representative Orwell or Senator Dingler, any final words you want to say before we let everybody go?
Sure, I'll just say once again, thank you all. We only get to design this new system with all of your feedback and all of your buy-in and all of your support. You know, I always say that we have a lot to be proud of in the state of Washington when it comes to so many different issues. And, you know, I could never say that, oh, we're leading in mental health, but I would love to. But through 988, we can actually say we're leading. And that is really meaningful because we have not led in this work in a very, very long time. And so, you know, I'll say what I've said so many times, that this is really that moment in time that we can design the system that we all know we need. So thank you. Please continue to stay engaged. We will continue to work on making sure the process works for everyone, the end result works for everyone. Just know that we're trying to balance a lot of different interests. And I'll just say, I'm just always thankful that everyone who's been coming to this work has been coming to it with the best of intentions, and it really shows. So.
Yeah, I want to second that. This is an amazing group of people, and there's so much expertise on this group and the community being involved. We're going to build a better system. It's going to take time, but I just feel so confident. We're off to a great start, and the system, you know, is really going to help those in need, and it's going to save lives. And I just want to say thank you for being part of it.
I apologize for offering a housekeeping item, but Senator Dingler, Representative Orwell, before you jump off, if you could hit save on your chat and then email it to HMA, that would be great, just to make sure we get everything. And with that, I'll let everyone go. You get a few minutes back in your afternoon. So thank you, everybody, and we'll see you in December.
Okay, I gotta say, I don't know how to hit save on my chat.
I don't either.
There's no, oh, save chat. I see it.
I can help.
Got it.
Okay. Representative Orwell, do you need a walkthrough?
Yeah.
If so, you know where you type in the chat, there's 3 little dots next to a smiley face.
Ah, okay, save chat. Okay, thank you.
Of course.
Awesome.